And then in 2018, she moved to her hometown to start her own clinic named Global Eye Care. And also, she is so passionate about academics. She worked in Vasan Institute of Ophthalmology, Malappuram. And in 2020, she became a total clinician. And recently, she opened her second eye clinic. And she is none other than Mrs. Juberia Feroz. So, with all respect, I welcome Juberia ma'am to start the session. Over to you, ma'am.
Good morning, all. Yeah. So it's a beautiful Sunday. You all are here to learn about low vision. Okay. Before any session, when I address a gathering, I always ask the optometry fraternity to think beyond pages. That is, we all know that after 4 years of degree, 4 years of learning, you're definitely going to be an optometrist. No doubt about it. Yeah? When there are a number of optometrists coming into the field, how do you distinguish yourself from the crowd? That is very important today, isn't it? All are optometrists. All know to do refraction, to put on lenses, to dispense contact lenses, and everything is being done by, say, 99.9% of those who have come out of the field. Now, how do you differentiate yourself, or how do you make out yourself to be a different optometrist? That is where specialization in optometry stands out differently. I want you to think of your passion. Optometry definitely is your passion, and that is the only reason that you're continuing with it. Maybe many of you might have joined the course by chance, not by choice. But then you are continuing and you have no other go. You have to complete the degree and you have to be an optometrist. Just being an optometrist is not enough today. Being the optometrist is important. And when being the optometrist is important, you have to think on what you are good at. Optometry has different dimensions. It is not just refraction alone that an optometrist does. There are so many other things, like we just list down contact lenses, binocular vision, you can say about orthoptics, oculoplasty, refractive surgeries. Refractive surgeries, how does an optometrist do? Does an optometrist do refractive surgery? No. No, right? Yes. An optometrist does not do a refractive surgery. But everything for a refractive surgery is planned by an optometrist. Is that true? Yeah. What does a surgeon do? A surgeon just fires the laser. Okay, so everything else is being decided, everything else is being calculated and done by an optometrist. So coming back, optometry is an independent profession. It is an independent profession. We are eye care practitioners. But many a times you will have a requirement or you will have to work along with an ophthalmologist. You might have, like certain cases, you alone can't take a decision up. You may have to go for an ophthalmologist decision or at least a discussion. But there are a few things in optometry where an ophthalmologist says nothing can be done. An optometrist with his head's high says, yes, I can help you. And that is low vision. Low vision is one portion, or it is one area of optometry, one area of eye specialization where ophthalmologists, surgeons, and many others are helpless and where an optometrist comes down to the patient to review what his requirement is actually. Yes? So we're going to look into what is low vision as a new perspective. Ashwati, can you please help me out to move the slides, or else shall I come forward? Yeah. Okay? So basically what we are going to deal today is very common, the normal terminologies, definitions of low vision, what are the different visual losses in low vision. We'll be dealing about the psychosocial aspects, which is very, very important as far as a low vision patient is concerned. Then evaluation assessment of low vision, and then a comprehensive rehabilitation system of low vision. So what is basically low vision? You might have just looked into the definition at least yesterday. Yes? What is low vision? Yeah, exactly. Low vision is a condition where the visual acuity is less than 6/18 in spite of standard refractive corrections, or the patient can't undergo any further improvement even with medications or surgeries. Such a condition is called as low vision. We'll just read out the WHO definition for low vision. A person with low vision is one who has impairment of visual functioning even after treatment or standard correction, and has a visual acuity of less than 6/18 to perception of light. Very important. That means a person with PL plus is also considered to be a low vision patient. Perception of light or a visual field of less than 10 degrees from the point of fixation. Either the vision is less than 6/18 or the visual field is less than 10 degrees, or both. Or is potentially able to use vision for the planning and execution of a task. That is very important. Okay? A person with a perception of light, what do you think a person can do with that? Perception of light, what can the person do? Any guesses? Perception of light, with that small amount of vision, what will he be able to do? At least he can judge out doors and windows of his room. A light is coming from this side, there is a window, some functional ability is there. So a person who can potentially use is called as low vision. If he is not able to use, a person has got 6/60 vision, but he is not able to potentially use his vision, there is no point in bringing him up for a low vision rehabilitation. Getting my point? Only people who can use the residual vision potentially can come under to the category of low vision. So that is important, a person who can potentially use for the execution of a task. Now, I'll give you a small case. A 10-year-old boy with best corrected visual acuity of 6/6 discontinues his school as he was not able to compete with his companions. This child, I had encountered this child at a blind school, and I was astonished to see a child with 6/6 vision studying in a blind school, Brain Libby. I was like, oh my God, why? And when I asked his teachers, his principal, they told that he was studying in a normal school, but since he was not able to walk and run and do all the activities with his friends, he was feeling insecure in that group. So his parents decided to bring him to this special school. A child with 6/6 vision, not able to do his routine tasks, he's put into a blind school. Now, we have a second case, a 50-year-old teacher with best corrected visual acuity of 6/60. Manages taking classes by reading softwares. His best corrected visual acuity, this is a lady, best corrected visual acuity was 6/60, but she manages taking classes. She continues doing her job. Okay, so my question is, who among them is a low vision candidate? First one, second one, both, none of them. Do they fit into the low vision definition? Both of them? Both of them? Second one? Okay. The second one fits into the low vision definition. What about the first person, the child? 6/6 vision, so he is not a low vision patient. Yeah. Then why was he put into a special school? His field was restricted to 10 degrees. He had 6/6 vision, but his field was restricted to 10 degrees, so he was not able to identify his neighboring places. He was not able to track things, so he had to walk like this. So when all his friends along with him run, he cannot run independently. So he was not able to cope up with his companions. That is the reason. So actually both of them come into the low vision category. So beyond the definition, there is something else for low vision that you have to understand. Okay? What you have to understand for low vision depends on two main points, that is activity limitation and participation restriction. This is important. Activity limitation and participation restriction. What do you mean by these two terms? Very important. When your visual acuity is not allowing you to do a normal task, when your limited visual acuity is not allowing you to do a normal task, that is called as activity limitation. And because of that limitation, when you're not able to perform a job or you have to quit something, that is called as participation restriction. So low vision candidates do have activity limitation. See, the first child could not independently move with his companions, so he had to leave his normal schooling. So not able to move along was his limitation, what was his activity limitation. The remaining friends were able to move, and this child was not able to move independently. So that is his activity limitation. And because of that activity limitation, he had to stop his normal schooling. That is participation restriction. He was restricted from going to a normal school. So he had an activity limitation, and thereby he had a participation restriction. So people who have activity limitation and participation restriction are said to have low vision. Okay. The second teacher, did she have any activity limitation and participation restriction? She definitely had an activity limitation. What was her activity limitation? With that 6/60 visual acuity, she was not able to take normal classes. She was managing by softwares, right? So normal reading and normal things was not able to be handled by that teacher. That is an activity limitation. But she didn't have a participation restriction. Because she continued her job. How? She coped up with her situation. That is how you rehabilitate a low vision candidate. That means though the child or the person has got any activity limitation, you rehabilitate the patient in such a way that the restriction is avoided. You make them to near normal. That is called as rehabilitation. What is rehabilitation? Making them to near normal. Understanding? So basically in low vision, what you have to check for is not what is lost. What the patient is having, what is his activity limitation, and because of this activity limitation, what has been the participation restriction. The child is not able to play. Activity limitation. Okay, so he does not go to playgrounds. That is his participation restriction. Like everybody else, he's not able to go to park. Like everybody else, he's not able to go to the circus because he'll not be able to see everything in a whole. Circus means everything happens in a 360 degree. So that is where you have to relate low vision from now onwards. Does this patient has got any activity limitation? Is there any participation restriction? That is how you get connected to low vision people. Okay. And now when we talk about low vision, we need to definitely talk about blindness because there is a very, very, very small subtle change between low vision and blindness. Okay? It refers to a condition where a person suffers from any of the following condition. That is total absence of light, that is PL minus. Total absence of sight, visual acuity not exceeding 6/60. That is what legally blindness is mentioned to be. Okay, legal blindness is less than 6/60. Okay, so when the visual acuity is less than 6/60, in the better eye, even with correction, that condition is also called as blindness. Limitation of the field is less than 20 degree. This is actually legal blindness, but as far as a low vision rehabilitator is concerned, everything up to perception of light negative is a low vision category. Now, why is this so important that you have to look into low vision? Why it is so important that we have to be so caring about visual impairment? You know why? You should know what is important. This is the latest statistics according to 2010. Now, what is the number of low vision? In 2010, almost 285 million people around the world are having visual impairment. It is not a small number. 285 million is actually a huge, huge number. Okay? And among them, 80% comes into the preventable blindness. That is important. This 285 million people are blind because of preventable reasons. 90% of the visually impaired, they live in countries like India, developing countries, proud to be an optometrist. And globally, uncorrected refractive errors are the main cause of visual impairment. Cataract still remains the leading cause of preventable blindness. Again, proud to be an optometrist. Yes. Age-related causes of visual impairment and blindness are increasing, and is blindness increasing. Top causes of visual impairment are refractive errors, cataracts, and glaucoma, including age-related macular degeneration in developed countries like US. Coming to the Indian scenario, the prevalence of low vision is 1%, that's fine, but then 13.3 million people are having low vision in 2010 and 16.7 million in 2020. And among the low vision people, only 15% of the low vision people are able to receive the services. That means the big major population of low vision have still not reached to the services. And only 10.6 million are in need of low vision care. So that is the huge number, the huge statistics of low vision. Then what's happening? See? 44% of the low vision is cataract, 16.3% is refractive error. And the remaining, yes, of course, retinal diseases still tends to be higher. Now, why is this important? Low vision care, is it important? Of course it is important. Only 3% of the visually impaired children in developing countries have access to basic low vision care. In children, almost 10% of the low vision category are children, and only among them 3% of the total child population having low vision have the access to low vision care. 50% of the visually impaired in special schools are low vision. That is what I was talking about. In blind school, when you go for a blind school visit, you can see the half of the population of the children studying there have vision, and they are learning Braille system. Why? Why? We don't have a special school for low vision children. where the child can learn with the remaining vision. We don't have such a system. Either we have a system for a person who has a complete developed visual acuity or a blind. So only that. So the difference between these two populations is a major thing which is not addressed yet. Low vision has enormous social and economic consequences in terms of productivity and independency. That is what happens. When you get low vision, you are dependent on somebody. So you get restricted yourself to within your home. That is what happens actually. Only Vision 2020 has been the world global initiative which has done anything for low vision. Nothing else in the world has been done for low vision. Where do we lack? We lack proper low vision rehabilitators. In Kerala, we don't have a low vision center yet. I think it's 2023 that I'm talking to. And Kerala still does not have a proper low vision rehabilitation center. Yes, we have eye hospitals with 5 or 6 magnifiers. Good quality low vision training programs. Optometrists are fond of low vision, but there is no space where you can train yourself, where you get patients to handle, where you can do good for these patients. So, and if at all we come up with some low vision rehabilitation, people around us are not happy using the low vision aids because they are not that cosmetically appealing. They look a bit bad. So because of all these reasons, low vision is still under developing. Okay, so what our role as an optometrist is, we need to know what is low vision, and hence you can come to at least a point saying that there is no low vision. A small briefing about it. So this is it. Visual acuity from 6/6 to 6/18 is said to be normal, and less than 6/18 is said to be low vision. Anything less than 6/60 is said to be blind, but when we talk about the functional vision, see till PL plus, it is said to be a low vision category. Okay, up to PL plus, it is a low vision category, but when it comes to the WHO categorization based on visual acuity, less than 6/60 is visual impairment, almost equal to a blind. Many a times we don't know what is the percentage of visual impairment. Okay, people asked, how much amount of vision have I lost? What is my percentage of impairment? So you can just have a look on the tabulated column. A person who has got visual acuity less than 6/6 to 6/18, that is from 6/9 to 6/18 in the better eye, and less than 6/24 to 6/36 in the worse eye, they have got a visual impairment of 20% because he is able to see with his best eye. Now, category 1, where the visual acuity is less than 6/18 to 6/36 in the good eye and less than 6/24 in the worse eye, that is a 40% of loss. 6/40 to 4/60 in the better eye, and 3/60 and less, that is a 75% of loss, 75% of visual impairment. And category 3, when it is less than 3/60 and a visual field of less than 10 degrees, and when you have counting fingers in the worst eye, it is said to be 100% of visual impairment. And a one-eyed person who has got a visual acuity of 6/6 in the good eye and counting fingers or less in the worst eye, the visual impairment is 30 degrees. So you need to know what the percentage of visual impairment is. Now we'll just have a discussion about these 4 terms, because these 4 terms are usually taken for granted and you simply keep on telling blah, 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 blah. Visual disorder, visual impairment, visual disability, and visually handicapped. You know, these 4 terms have different 4 meanings. You should not use one for in space of the other. All 4 have different meanings. Can you give me what are the meanings? What do you mean by visual disorder? Visual impairment? 30% of visual impairment, 20% of visual impairment, 75% of visual impairment has been discussed. What is visual impairment? What is visual disorder? Everything is the same. What's the difference? Anybody? You'll get a candy from me now. Visual disorder. It is a disease condition that has led to the low vision. That is disorder. For example, a patient has got ARMD. ARMD is the visual disorder. Okay? Now what is visual impairment? Cataract is the visual impairment? Yes? Glaucoma is a visual impairment? Yes? No. No. Visual impairment is the result on the visual acuity. What amount of vision has been lost? That is visual impairment. What is the visual impairment? 6/24 is the visual impairment. What is the visual impairment? PL minus is the visual impairment. The result on the visual acuity is visual impairment. The condition is visual disorder. Okay? So please don't replace it, because I've heard n number of times, even I used to talk, cataract is the visual impairment of this patient. Cataract is not the visual impairment of the patient. Cataract is the visual disorder of the patient, and 6/60 is the visual impairment of the patient. Okay? So when somebody asks what is a visual impairment? Visual impairment is the visual acuity. What loss patient has got because of that condition. Okay? And because of that, if he is not able to do anything, that results into visual disability. Okay? Visual disability means he is not able to go to normal schooling. He is not able to drive. That is his visual disability. And there is a major difference between disability and inability. Disability and inability. I am not able to drive. Is that my inability or my disability? Inability. Disability? Inability? Yes? I am not able to fly. My disability or my inability? That is my inability. I am not able to drive. Disability. What does that mean now? That's okay. I am not able to drive is my disability. I am not able to fly is my inability. What does it mean? When my other companions can do and I cannot do, that is my disability. When none of us can do, that is our inability. Humans cannot fly, that is human inability. Okay, humans cannot fly is human inability. But I cannot sing, that is my disability. Okay? When my friend can sing, I am not able to sing, that is my disability. Understanding? So disability, inability, please don't take these words for granted. You keep on replacing, this will also go, that will also go, ye bhi chalta hai, wo bhi chalta hai. You should not do that. Okay? So, remember what is visual impairment, remember what is visual disability. And there is a last term called as handicapped. I don't like taking that term because there is nothing like handicapped. Handicapped means hand in a cap means a beggar. Nothing like that. But we say visually disabled or visually handicapped means when all the other people can do something he is not able to do, that condition is called as handicappedness. Okay? That's all. Yeah, a small thing. ARMD is a disorder. Decreased central visual acuity is an impairment. Is not able to read and recognize faces is his disability, and thereby he is not able to move into the society. He is not able to attend a marriage function. That is his handicappedness. Okay. How does a low vision affect? It is not simply the loss of visual acuity. Okay. It is not like, how many of you have got a refractive error here? a few of us, okay? See, when you take off our glasses, the vision is blurred actually. And when you put back your glasses, it's fine, thanks to the Almighty. Low vision is something which actually affects the quality of your vision. More than the quantity, the quality is affected. And how it is affected is, any condition, any disease condition of low vision can come under any of these vision losses. Either the patient can have a central field defect, central field is lost. He is able to see everything here, but where I am looking on to, I am not able to see. Central field loss. Or else, peripheral field loss. I can see everything in the center, but my periphery is lost. Remember my child? 10-year-old boy, 6x6 vision. Still he is not able to do things because he is having a tunnel vision. Okay? So either you will have a central field loss, or you will have a peripheral field loss, or you may have an overall blur. That means everything is blurred. Distance, near, center, periphery, everything is like vaguely you see. So any condition that affects low vision can result into any of these three conditions. Either you have a central field loss, peripheral field loss, or an overall blur. Can you give me some diseases that affects low vision? ARMD, glaucoma, cataract, diabetic retinopathy, refractive errors, high refractive errors. Stuck on. RP, ROP, RD, then anything else? Any new? Albinism, very good. Albinism. Aniridia, super. Then? Achromatopsia is actually not a disorder, it is a condition, yeah. Okay, so that's enough. See, we'll just look into certain diseases that causes, see, this is how you see in cataract. Cataract, you see an overall blur. That is an overall blur. Again, this is a macular degeneration. You are not able to see the center portion. Okay, center is invisible. This is how you see for a overall blur in diabetic retinopathy. See, you are seeing the child somewhere blurly. Now, these are a few conditions that may lead to an overall blur: corneal dystrophy, keratoconus, microcornea, congenital glaucoma, cataract, vitreous opacities, and Marfan syndrome, where you have a dislocated lens. There is an overall blur. Central field loss, a condition that affects your macula. When macula is affected, you have a central field loss. Example, there are so many conditions: Best disease, Stargardt's, achromatopsia, albinism, macular coloboma, AMD, myopic maculopathy, diabetic macular edema, chorioretinitis, and retinal vascular conditions like CRVO, CRAO, and such things. Peripheral field loss, you have a clearer central vision, but you see through a tunnel. You're not able to distinguish your neighboring space, and then hence you're not able to move. Diabetes, that is advanced diabetes, retinitis pigmentosa, LCA. What is LCA? Leber's congenital amaurosis. Glaucoma, optic atrophy, ROP, intracranial lesions. Everything leads to, what are these conditions? Peripheral field loss. Peripheral field loss. Okay. Now coming to very important thing. Now that we have understood how you see a low vision patient, okay? What is lost? What is lost? Patient loses his quality of vision. Okay, that is important. When you try to improve, you are neither able to improve the quantity nor the quality. So the major concern is 6 by 18 is there, but that 6 by 18 is not as good as your 6 by 18. Understanding? I am having 6 by 9 vision, but my 6 by 9 vision, I am not able to see what's happening in my side mirror of my bike or my car. I'm not able to drive. I have 6 by 9 vision. What to do? I cannot drive. Understanding? So the quality is decreased. That is important. And you understand there is a decrease, there is a visual impairment, there has been a loss in the visual field, and there are certain conditions that may either create an overall blur or a central field effect or a peripheral loss. Now, handling a low vision patient is not that easy. What is the most challenging being an optometrist? Which category of people are most challenging? Pediatric. Agreed. Pediatric. Why pediatric? Why pediatric? Huh? Non-cooperative, you cannot actually summon up that way. Handling. Thing is, they don't understand why are you doing this. That is the main reason. Okay? You ask them to sit here, you ask them, no, what did you eat? Very nice, good dress, good bangle. And they'll be thinking, why is this lady talking to me in this way? Why can't she talk in her normal tone? Child might be thinking, because I usually, how are you, baby? That is the way we talk to a child. Okay? The child may not understand what is actually happening here. Okay? I had a child from Malaysia. I mean, she was a Malayali, but she was born and brought up in Malaysia. She was a 4.5-year-old child, and she was like sitting on my chair unit upside down. And then she was saying, I cannot see. No, I cannot see. I'm sorry, I cannot see. And I was saying, please read that for me. Can you please read that for me? So that is the way we beg children. Why? Because the child is not able to understand what is happening. When you deal with a low vision patient, you understand that children are far much better. At least if you show this way, he will at least read 6 by 6. But this is not going to work with a low vision patient. Okay? Now this is perception from optoms to optoms. It differs. As far as I am concerned, children are far better than low vision. Because when you have to encounter a low vision patient does not undergo through a normal psychological mental status. Understand? That is why this is challenging. A normal patient, a very normal person who loses his vision one fine morning. He's not able to see himself in the mirror. He wakes up and he washes his face and he's not able to see himself in the mirror. He's not able to see where he is able to see. Getting me? Just assume yourself. Just assume yourself. No, I cannot assume. Just assume yourself. Will you be normal? No. So we are going to deal with the psychological aspects or how psychologically low vision affects a person. It is not that always a low vision patient will be like that, but a low vision patient has to undergo a number of stages to understand that, yes, I have got something wrong. Okay? Now, this is different. When you're born with low vision, that is different. And when you get low vision in your second or third or fourth decade, that impact is different. Understanding? So now, what are the psychological aspects of low vision? See, this is what I was telling. One day you get up and you don't find yourself in the mirror. It is I can't even tell that in words. That would be the feeling, right? The first thing we do is we see ourselves. That is the confidence of the day. So these are the stages. First, very good to read and very good to understand, but very good to undergo. Not that good to undergo. Okay? The first reaction would be a shock. A shock. He won't be able to believe that he has lost something, and that shock would trigger his anger, would trigger in different way. Okay, either the patient, I mean, first thing will be like he will deny everything. He will deny everything. I still remember an old man who came to my clinic way back in 2010. My initial encounters with my patients, I remember as each day I cherish it. Those has been my memory, unforgettable. So I had a patient around 60, 65 somewhere. And he came to my low vision rehabilitation center at Al Salama, and we were just talking. So I was like starting my discussion, starting my communication with that father. I was asking in Malayalam language, like, what happened? When did you realize that you're not able to see? And I was slowly asking things. He just got up, and whatever there was on the table, he just wiped it off. And he started shouting like anything. The same questions I have been asking 100 times that I have entered your hospital. I am telling, no, I'm not able to see, I'm not able to see, I'm not able to see. That is what he shouted. And just next to low vision clinic was a contact lens clinic, and a person, my colleague, came out and, what happened? I don't know, nothing, low vision. So that is low vision. The first reaction, I mean, first means not the first day. It would take some few months, okay? That stage of reaction would be like, he will be in a shock. He'll not able to believe that he has lost anything, and he will actually deny that. When we say or when we ask, Upa, can you see this? Yes, I can see. Can you read your newspaper? Yes, I can. Like, he will deny that he has not lost anything. That is the first stage. Quite difficult to do a rehabilitation at that stage. Very difficult, because he will not accept your magnifiers, he will not accept your evaluation process, he will not accept anything. He'll say, everything, I have some bloodness, that is enough, that will get all right. My sugar levels are high, I will become all right. That is the way he will manage himself. So that stage of low vision people, don't start rehabilitation. Just send them back, ask them to come back after 3 or 4 months according to the situation. So that is the first thing. They'll be having immense anger. They'll shout at you. Not only at you, they'll shout at people at home also. Their wife, the children, everybody. So you have to counsel their companions at home, telling that he's undergoing this process, so please be with him. And then that denial will slowly lead to a depression. A depression knowing that he's not able to read a newspaper. He's not able to see himself in the mirror. That will lead him to immense sadness, grief. That is depression. And this stage, you can see patient crying in your clinic. I had a lady who was breastfeeding, and she lost her vision after she delivered the child. So she did not look at the child, she did not care for the child, realizing that she lost her vision after this child took birth. So she was trying to blame somebody. That happens in low vision. You try to blame a doctor. After doing my laser surgery, after doing my laser treatment, I have lost my vision. That doctor does not know anything. I've lost my vision only because of that laser treatment. Because they try to find out a reason for their loss. They try to blame somebody. So this lady was not caring and loving for her child. The child was around 3-4 months. So in my clinic, I started talking with her. And then she started weeping like anything. She started crying like anything, because she was in a state of depression. In this state, people don't talk to you. You ask task-related history. You ask, do you do this? Can you do that? What has happened with you yesterday evening? They don't talk. They keep mum. They are silent. So you can't take a proper history. You can't do an evaluation in that stage. That is a stage of depression, stage of grief. Okay? Either they are very silent or they start weeping for each question. So that is another stage. Second stage, after that immense anger, they become silent. They don't talk to anybody. That is the second stage. Then, fourth stage, where they come and start bargaining. Bargaining means, can anything be done? Is there any glasses that can help my vision improve? Can you do anything for me? That stage is an okay stage to start to look into what the patient has actually got. So that is the bargaining stage. And finally, after bargaining, he realizes and he accepts that, yes, I am a low vision patient. I cannot see with my normal glasses. I need something additional. I understand this is a condition that I have to live on my whole life hereafter. And that is the final stage of acceptance. So this storm or change in your life brings about a major change. And finally, when the patient is in the bargaining or acceptance stage, only then can you start doing a rehabilitation. Okay? So low vision is it's not that patient comes, you evaluate and you say these are the glasses or these are the magnifiers that you have to use. The patient keeps on the magnifier. Yes, I can see everything. No. Patient will not respond sometime. Patient will sometimes shout at you. Patient will sometimes say, you don't know anything. I am able to read everything. You don't know anything. You just go out of hell. So you can have different way of a reaction from the patient, and you have to be ready, understanding that these are not normal people. They are undergoing some psychological changes in their life. So you have to be patient enough. You have to have the perseverance to cope up with the patients. Okay? Now, see how a patient won't go abnormal. Why won't a patient go abnormal? When you lose a vision, when you have a vision loss, what all do you lose? You have your psychological security. Okay, you are not normal. You understand that something is happening with me. I used to regularly do this. I'm not able to do it now. See, a mother who cooks for the entire family, suddenly she loses her vision and she's not able to identify salt and sugar. She's not able to identify salt and sugar. How do our mothers check for salt and sugar? Every time they taste and see, they know where it is kept. They know in this dabba it is salt. In this dabba it is sugar. They take it, they put it. They don't even see for it. They'll be talking. Yes, I know. And then one fine morning, my mother is not able to identify salt and sugar. Will she be normal? So, those are few reasons. You lose your basic skills. Basic skills like your basic skills that you're not able to dress up. Okay? You're not able to take a selfie. Not able to take a selfie because you're not there in the mobile phone. Your basic skills are lost. Your communication is lost. What do you mean by communication? What is communication? I'm communicating with you. Yes? You're looking into my eyes. I'm looking at your face. I'm able to see your faces. You're able to see my faces. And that is a way of communication. It is not simply hearing. See, I can see few people communicating with me like this. They're closing their eyes and they're listening to everything that I'm telling. Is that communication full? When you see, you know better. So that communication is lost. And then you cannot appreciate things that you don't know that there is a table here. You're not able to appreciate your field. Everything is lost. Your occupation, your financial status, your whole personality is lost. So you need to know that a low vision patient who walks into your rehabilitation center is undergoing a tremendous psychological impact. Okay, so these are the psychological insecurities. We talked about all these things. What is a picture? Tells you. Huh? Anybody? A picture itself is a communication, right? A picture says everything in it. What does this picture say? What does this picture say? This implies something to low vision. It's nothing like the image of a low vision patient is something different than that you see. Okay? It is beyond what you can imagine. The image or the social impact or the psychological impact of a low vision patient is different than you imagine or you tend to see. Only this much is like. Okay? I'm a low vision candidate. I'm not able to take classes. I'm right. I have lost my vision, but I can take classes. I'm right. Understanding? It is how you perceive the situation, how you cope up with your situation. Yes, you have lost, that is okay. But with that loss, how you move forward is it depends on you. So that is important. Okay? Yeah, so that was the introduction of low vision. We'll have a small break now. Any doubts so far? No doubts? Okay, so we'll start back. No? Why? It's boring? Boring? Okay, thank God. Live start ida. Start ida. Okay. So now that you have at least understood 5 to 10% of what low vision is, how you have to at least think about low vision. Will you ever decide to be a low vision rehabilitator? No. Okay? So that was the first introductory part to make you understand that this is not an easy task. It is not at all an easy task. Being a pediatric optometrist is far, far easier than being a low vision rehabilitator, because each and every condition, each and every situation, the implication, the impact, everything is different from different. Okay, you have two patients with ARMD, both with ARMD, but patient A will be responding in a different way, patient B will be responding in a different way. Patient A's requirement is different, patient B's requirement is different. It is not that ARMD, 10x magnifier, there is nothing like, what do you say, a standard protocol that you have to give this to this condition is this, nothing. It is trial and error method. You have to think. Okay? Being a good optometrist, if you have to be a good optometrist, being a good optometrist, the three requisites that you should have is, you know what? One, knowledge. Without knowledge, nothing is possible. Okay? And where is knowledge? Brain. Second thing, you should have skill. You know what is low vision, you know the definition of low vision, you know how disorder and vision impairment is different, you know what is a Stargardt's disease looks like, what an ARMD looks like, you know what a Best disease looks like, you know what is Eagle's disease, everything you know, but you are not able to handle a patient properly. That means you lack skill. And where is skill at? Skill? Which organ? Which organ gives you proper skill? Hands. As far as an optometrist is concerned, your hands are your magics. Okay? So you need to have brain and you need to have hand. And the third, and the most important one, what is it? Knowledge, skill, attitude. And where is your attitude? In your heart. Unless and until you have brain, hand and heart, you should not continue this profession. Okay? Even if you don't have brain, you can continue if you have a good heart. Even if you don't have hands, you can continue if you have heart. But without a good heart, there is no meaning in continuing with a powerful brain and beautiful hands. Understanding? Realizing the patient, empathizing the patient, understanding the patient is the most important thing when it comes to low vision. So evaluating and assessing a low vision is beyond, it requires beyond your knowledge and beyond your skills, something extra is required. And that extra is your attitude towards these patients. Clear? So we'll just look into what is the evaluation and assessment process of low vision. Evaluating a low vision patient, you have preclinical assessment and clinical assessments. Okay? In preclinical assessments, you need to understand the prognostic factors and the psychological factors. Prognostic factors means, see, you cannot clear the damage. You're not dealing to clear the damage. You know the condition may worsen. This patient is having 6/18 vision now, but after 3 months or maybe after 6 months, his vision would be less than 6/60. So you need to know how the prognosis of the condition is, what the future of the patient is. That is the biggest challenge of low vision. It is not like a patient continues to stay in the same visual acuity lifelong. It is not the same visual impairment that the patient has to deal entire life. It changes. It keeps on changing. It keeps on changing. So you should have a clear idea about the prognostic factors. You should have the clear idea about the psychological factors. Understanding whether an assessment is required now or not. Okay? When do you start a good assessment? Only once the patient is in the acceptance stage. Patient realizes this, yes, I have got an impairment and I have to get corrected. Unless and until the patient is not that in stage, there is no point in assessing and evaluating. So the psychological factor and the prognostic factors, both you have to keep in mind and then start your clinical evaluation. Okay? So these are the prognostic factors: the duration of the condition, etiology, the stability, the visual acuity, visual field, patient's age. Okay? Now, there is no point in rehabilitating a 75, 78-year-old grandmother who does not do anything in the home. Okay. So, her age, her social status, her motivation, her flexibility, everything matters before evaluating and assessing a low vision. Psychological, in which stage is the patient undergoing? Is the patient in a denial stage, grief, anger, depression, or acceptance stage? Now, certain factors that influence your low vision assessment, it depends upon the visual acuity. Visual acuity. If the visual acuity is between 6/36 and 3/60, there is a chance that the improvement is good. But if the visual acuity is less than 1/60, the prognosis is poor. Understanding? The result would be poor. And if the condition is either congenital or within 1 year, then you can have a good prognosis. But if it is a sudden onset, then the prognosis is bad. Okay, if it would have been a congenital disorder, then you know that this condition will stay long. This is going to happen. So you can understand the prognosis. Motivation, whether the patient wants a low vision rehabilitation or not. Patient does not need anything and you are forcing the patient to take it up. There is no point in doing evaluation. Flexibility, the willingness of the patient to use that. Then the visual field, of course, if it is less than 10 degrees, then the prognosis is quite poor actually. Stability of the visual acuity, if the visual acuity keeps on deteriorating, it's quite difficult for the rehabilitator to handle because he takes up a magnifier with that current visual acuity and he goes back after 2 months, he is not able to see the magnifier. There is no point when this visual acuity is not stable, there is no point in rehabilitating. What condition? Etiology, age, and the understanding of the patient. If the patient is educated, he understands the condition, then rehabilitation is much easier. So all these things influence the success of a low vision aid. It is not like you get an ARMD patient, come on, yes. There must be consent from the patient. Patient must be ready for the rehabilitation. Patient should understand that, yes, this person can help me. A patient is ready to tell what my problems are. So it is actually a give and take thing. Preparedness of the patient is very important. The condition of the patient, the possible prognosis, and the need of low vision services. The patient also should understand all these things. So what is clinical assessment? How do you assess a normal patient? Normally, what are the steps that you do in your refraction clinic? You start with the visual acuity, distance visual acuity, near visual acuity, unaided and habitual visual acuity, and then you can go for a refraction. You start with an objective refraction, and then with the subjective acceptance, then with the binocular functioning. You also do certain, if importantly, the patient has got some binocular vision anomalies, then you go for an orthoptic evaluation. And that is how you stop down with a refraction case. Is that not the same with low vision? What is so different with low vision evaluation? Contrast. Contrast. You have to check for contrast in low vision, and contrast is usually not a routine procedure. Yes, contrast is one thing that is different, that you routinely don't do, but you have to routinely do it for a low vision patient. Then contrast is one point. Mirror. Glare. Contrast, glare, then mobility, then anything else? Okay. Is the refraction in visual acuity same? No. Even before you talk about contrast and glare and that and that and that, visual acuity testing itself is different. Refraction itself is different. So let's talk about that first. Okay? So we are dealing with function. His foot is different. The way he walks is different. Okay. See, when I walk, I don't scan this way. But if I'm a low vision patient, I have to check my sides because I may bump into objects. See, now when I crawl on this step, I actually don't look into where the step is, and yes, my next step is here. But if I'm a low vision patient, I have to be aware of where my next step is. Is it down? Is it up? Is it flat? Everything is important. So, the functional vision loss is what happens with low vision. Okay? See how a functional vision loss affects the behavior. Okay? We are just looking into that. When you have a loss in visual acuity, what is the behavioral aspect? You may have difficulty in reading. What reading? Reading anything. Reading your textbook, reading the newspaper is different. What reading? The speed of reading is different. Okay? See, I have got a visual acuity, I have got a decreased visual acuity. Though I have got a reduced visual acuity, I am able to read. Okay? But my same visual acuity, a low vision patient comes, the speed of his reading will be different. That is the behavioral aspect. The way he reads will be like loss of visual acuity. Because why? He will have to search for each and every next word. Then only he'll be read. Then only he'll be able to read. Okay? But now when I see, I can see everything. So I'm reading at a different speed. So that reading is different. His reading is different. When we are studying in first standard, my grades will be different, his grades will be different. Why? Not because he's not able to see, because the quality of his learning is different from my quality of learning. Understanding? So recognizing patterns, recognizing faces, facial expressions. So when I look at you, I understand whether you are listening to me, you are caring for me, where you are angry with me, you are happy with me, you are sad with me. Now if I am not able to identify her face at this distance, I'll be vaguely able to see her expression. My communication is lost. I don't understand what actually she means. Now I look at you like this, you know that I am not happy with you. Right? And when you are not able to see my face, you don't know what my connection is with you. So you're losing the connection with the society when you don't have a proper visual acuity. Okay? Now, you can have a good visual acuity, though you have a loss of contrast. And when you have a loss of contrast, you bump into objects. What does loss of contrast means? When you have a decreased contrast, what happens? You're not able to identify the object from its background. Okay. See, if I have a loss of contrast, I'll not be able to identify there is a phone here. For me, it will be a flat surface. Okay. So that is the difference. And understanding the objects. So I don't know that there is an object here. I may bump into it. I may fall down. It will be difficult for me to identify the way, path in dim illumination. Writing in straight line would be difficult. That is all because, not because of visual acuity is less, only because of contrast is less. Okay. Now sensitivity to light, that is, I'm not able to bear this light. If I'm not able to bear this light, what will happen? Automatically I'm not able to see. right? Glare is affecting me. Photophobia is there. So I'll tend to close my eyes and my quality of vision decreases. I'll not be able to move out. I'll not be able to drive. Everything is hampered. My poor color discrimination. When I'm not able to identify colors, what kind of life am I having? Think about it. You're able to see everything, you're not able to identify colors. What's it? So that is the kind of loss that you have with low vision. Clinical assessments, these are the routine procedures that you carry out for a low vision assessment. You have a general observation, you have a detailed history. Why this long, this history? Because this takes that much time. Okay? It takes a detailed history, that is very important. Assessing visual acuity, refraction, assessing the visual field. See, visual field is not done by HFA or octopus. It is done normally by confrontation test for the peripheral field and Amsler's for the central field. Color vision testing, usually D15 is the standard procedure for low vision. Yes, you can do it with AGR as well. Contrast sensitivity testing, usually with peliropsin. Low vision aid trial is done, selection of low vision is done, and then instruction and training, and then a proper referral. So this is what happens at a low vision rehabilitation. Okay? Yeah. Now coming to the general observation, you simply observe the patient. What do you observe for? How the patient walks into the clinic. Who is along with the patient? Is the patient able to move properly? Okay? Is the patient scanning? If the patient is having any glare or photophobia, at that first look itself, you can identify numerous things that you need not ask again with the patient, right? How the patient is able to, how independently the patient is able to move, how is the patient's head posture, how good the patient looks, cosmesis, that is, you can have a corneal opacity, any such cosmetic blemish on the eyes, and the routine physical factors, how the patient looks and things like that. So many general observation that helps you out to give a clear picture. Then this is what I was talking about, a detailed history. Okay? Detailed history is not the routine history that you say, that you ask, how long have you been using glasses? When was the last glasses changed? Are you comfortable with your glasses? Do you have any other medications for your general health? Do you take any regular medicines for your eyes? Is anybody glaucomatous or having diabetic problems in your family? It is not that general history. Yes, of course, that general history is required. But more than that, who is jumping into it? Okay. More than that, task-related history is important. Task-related history, that means you ask, are you able to see the blackboard if the child is in a studying class? Are you able to see the blackboard? Are you able to see television at your home? At what distance do you watch television? Are you able to recognize your friends' faces? Are you able to identify your mother at that distance? Are you able to eat properly from your plate? You know that? If a patient has a loss in contrast, patient will not be able to identify what is there on his food plate. That means what all chammandi and chutney and upperi, whatever is there, he won't know that unless and until he tastes. See, when you see your plate, you know what is there. And you just assume a child who is not able to identify colors, who is not able to identify the contrast, how he will be eating. Not a child, even a grown-up person will not be able to eat properly from his table, from his plate. He will not be able to sit on his dining table properly. So that small, are you able to write in a straight line? Can you read fluently? Do you read your textbooks? That type of task-related history is important for distance, for near. What about your vocational things? How do you spend your routine time? Do you listen to audiobooks or you listen to music or that way? That small things. What I used to ask and all is like, can you identify your coins? yeah, are you able to see better in outdoor light or indoor light? So that gives you a clue about glare sensitivity and all. So that kind of small open-ended questions. Open-ended question means not yes or no question. Can you see in a dark room? No. Can you see outside? No. Can you identify coins? Yes. What are these questions? These questions are not open-ended. These are closed-ended. Either yes or no. Only that are the responses. So such type of questions are called as closed-ended questions. We need to ask open-ended questions. Open-ended questions means, what is your general difficulty? Where do you find more difficulty? I find it more when I play outside. I find it more difficult in the afternoon when I come out for my lunch. So you need to ask in a way where the patient can open up and talk. That is called as open-ended questions. Okay? So with that detailed history, we'll just have a small tea break now. Yeah, I know. Okay, so break for now. fresh after your break? No. No, yes. Okay. So we'll start with a clinical assessment in low vision. First one is the visual acuity testing for distance. When we talk about visual acuity measurement, as I was telling, even visual acuity measurement is different from a normal testing. What is the difference is, we use a standard chart at a non-standard distance. See, what chart is that girl showing? Logmar. What is the logmar testing distance? Four meters. Logmar is 10 to be tested at 4 meters, but in low vision clinic, you test it at 3 meters or 2 meters, wherever the patient is able to read. Okay, so you use a standard chart at a non-standard distance, and then you allow the patient for eccentric viewing. If the patient is reading this way, let him read it that way. What you're trying to get is the maximum vision he is able to read. You start with the good eye. You start at the least distance that the patient is able to appreciate the letters on the chart. What are you trying to do is, you're encouraging the patient to read. It is not like you cannot see, not able to see, then that's it. No. You try to make the patient read it any way the patient is able to. You don't use phoropters for low vision trial and refraction, because phoropters hampers their eccentric viewing, and that they may have some kind of adaptation, facial adaptation, some face turn or something which can improve their visual acuity. So that may be blocked with a phoropter. So phoropter is usually not used, and you allow the patient, how the patient is able to read, you allow them, encourage them to read it. So that is one important thing. You use standard charts and a non-standard distance for distance visual acuity measurement. Now, talking about the refraction is also different. How it is different? Objective method is not done using an AR, it is done using retinoscopy. And retinoscopy, you do radical retinoscopy. What is radical retinoscopy? Retinoscopy, which is done at close distance, near distance, okay? Usually you do it at 67 centimeters, and that is the normal working distance, or say 1 arm distance. So you can go to 50 centimeters and you can do it at 1 meter as well. It depends upon your convenience, but usually 1 arm's length, that is the normal procedure. But in radical retinoscopy, like in constricted pupil or smaller pupils or central opacities, cataract and things like that, you go and maybe as close as say 10 centimeters, 10 to 15 centimeters, and you do the retinoscopy to get what kind of movement do you get to see. Is it a with movement or an against movement? What kind of? So that close distance retinoscopy is called as radical retinoscopy. And off-axis retinoscopy, same way. Retinoscopy is done at on the axis, at the visual axis. But in a low vision patient, how you do it is, you do you do the left eye retinoscopy at the right side and the right eye retinoscopy at the left side. That way. Okay, not at the center, because at the center you may have a central opacity, corneal opacity or cataract. So you may not get the reflex. So in order to get the reflex, you'll be out of the focus, out of the axis, and then you do retinoscopy. You do retinoscopy at closer distance. So that kind of objective method is applied in low vision. In subjective refraction, you use these two techniques called as bracketing technique and JND. Are you aware of these two things? You know what is JND? JND stands for just noticeable difference. Just noticeable difference. Okay? Do we have a JND for normal refraction? You actually have not heard about it, but yes, we have. JND is very important for low vision. See, when you do refraction, you get a visual acuity of say 6 by 60. Unaided visual acuity is 6 by 60. With what lens do you start? 0.5 plus 0.5 minus 0.5. Will plus 0.5 minus 0.5 do anything? No? With plus 1 and minus 1 do anything? What am I asking? A normal patient. Normal patient is sitting in front of you. You check the unaided vision is 6 by 60. What lens do you take from the trial frame? You start with a spherical lens, of course. So will a plus 0.5 or minus 0.5 do any change for the patient? A plus 1 or minus 1 will do any change for the patient? No? Yes. Patient will appreciate a change. Even with 0.5 also the patient will appreciate a change. Okay? It is not like patient will read 6 by 6. But the patient can say, yes, this is better or this is not better. Right? But for a low vision patient, a 0.5 or 0.75 is not going to create any difference. Understanding? So, in order to make a change, in order to have an appreciable change in the vision, you need to calculate what is J and D, what is the just noticeable difference for this patient. That is important for low vision. And based on J and D, you do a bracketing technique, and that is how you start the refraction for a low vision case. Now, how do you calculate the J and D? When the visual acuity is calculated at 20 feet, okay? When the visual acuity is calculated at 20 feet, J and D is calculated by dividing the denominator of the best corrected visual acuity by 100. When you are calculating, when you are recording the visual acuity at 20 feet, the denominator of the best corrected visual acuity is divided by 100. For example, if the visual acuity is 20 by 200, 200 by 100. How much it is? 2 diopters. 2 diopters is the J and D. Just noticeable difference is 2 diopters. Okay. Now, if the visual acuity is calculated at metric method, that is 6 meters, 6 by 60, then the denominator is divided by 30. In feet method, the denominator is divided by 100, and in metric method, the denominator is divided by 30 in order to get the J and D. So, J and D is 2 diopters. Okay. For a patient with visual acuity of 6 by 60, the J and D is 2 diopters. Now, what does the 2 diopters mean? This 2 diopters is put into a bracket. You take 2 values which gives you a 2 diopter difference. So, 2 is divided as plus 1 minus 1. That is the bracketing technique. Two diopters is the J and D. You bracket it into plus 1 minus 1. That means if unless and until, plus 1 or minus 1 only can make an appreciable change for the patient. If you put a plus 0.5 or minus 0.5, the patient is not going to appreciate a difference. Plus 1 or minus 1 can make a change. Okay. Now, if plus 1 and minus 1 patient is not able to appreciate, patient feels no difference, then 1 diopter is added, you take it with plus 2 minus 2. Okay. And then if plus 2 and minus 2 is not done, then you do for plus 4 minus 4. That is the way you do bracketing technique. Understanding? You find out the J and D, and then you bracket, and then you find out whether any change is there for the patient. First, a clear distance refraction has to be done before a low vision trial is done. Okay? So, you need to evaluate the distance visual acuity properly, and then a proper refraction is done using the J and D and bracketing technique method. Hope it is clear. Any doubts? Feet method, you divide the denominator by 100. Metric method, you divide the denominator by 30. Assessing the visual acuity, you have very good visual charts. You start with the better eye first, so that the patient is happy that he is able to read something, okay? And if you know that the patient has got a uniocular vision, then there is no point in occluding one eye. Let the patient read it binocularly, okay? You break the normal standard norms, and you help the patient, you encourage the patient positively that the patient is, I can read something, okay? Because the patient would have undergone a routine visual acuity testing and a routine refraction, and the patient would have maybe under the belief that I am not able to see. So when he comes to a low vision clinic, you are trying to show something else. You are improving the visual acuity. You are not actually improving the visual acuity. You have reduced the vision distance, and then the patient is able to read. That changes the mental impact of the test. Okay. So, that is it. You test with better eye. You test it at 2 to 3 centimeter distance. You test with patient's habitual visual acuity, habitual glasses, and the largest available letters which is able to, which is seen by the patient. You start with it. Even if the patient has got an eccentric viewing and an eccentric fixation, you try to do that. What is the difference between eccentric fixation and eccentric viewing? Both are same? Yes, boys? Eccentric fixation and eccentric viewing are same? No? What is the difference? Get me the answer before I leave. Okay? By lunch break, give me the answer. The first thing that I'm going to ask after post lunch is what is eccentric viewing and eccentric fixation. Okay? These are not same, one thing for sure. Okay? Then check for the quality of response. You encourage the patient, even if the patient reads 1 or 2 wrong letters. Yes, okay, next, that way. You pamper the patient. Monocular and binocular visual acuity is tested, and then instead of giving continuous text, you may give single letters also. Sometimes single letters, the visual acuity would be better. Charts, you should be able to move. No fixed charts in low vision centers. They must be movable. The charts must be able to change the illumination. High contrast charts are required, as well as low contrast charts should be there. And good range of optotypes, equally legible letters. So that is why we use Logmar and ETDR as such charts. So these are some charts. Lighthouse chart. Sloan letters are used, and the distance is done at 1 meters, 2 meters, and 4 meters. Logmar optotypes are used in lighthouse charts. This is Feinblum charts, single letter charts. Movable flip charts are there. Visual acuity ranges from 20 by 10, 1 by 700, in that way. High contrast chart, these are more sensitive at lower levels of vision when the vision is very less. Instead of going for normal Logmar chart, you can use Feinblum charts. Okay, specially designed for low vision visual acuity testing. Okay, now usually you don't use Snellen chart in low vision clinics. Why? Because the Snellen, as you all know, Snellen chart have their own disadvantages. The proper vision recording is not actually done with Snellen charts, so that is the reason you don't usually use Snellen charts. ETDRS, we all know, the very common one, ETDRS, Logmar, all similar. 5x4 non-serif letters are used. It can be used at 1 meters, 2 meters, 3 meters. The standard distance is 4 meters, but you can use it at 3 meters, 2 meters, and 1 meters as well. Okay, and ETDR's chart are available for kids also in HOTV type and Landau C type. These charts. So only such standard charts are only used in low vision rehabilitation centers. Ferris Logmar, similar to Logmar, but Logmar chart is a 5x4 Sloan letter, and Ferris Logmar chart is a 5x5 Sloan letters. What is 5x5, 5x4? Know that? Okay. The letter is put into a square grid. The size of the square grid can be 5 height and 4 width, that is 5x4. 5 height and 5 width, that is 5 by 5. Okay. Now, near vision charts. Near vision charts, again, reduced Snellen charts are there, but usually you don't use. You use near logmar charts. And M notations are usually used for near vision recording. You all know 1M is equal to N8, and such optotypes are used in near vision recording. So these are the N scale and M scale notations, very important, you need to understand. Why? Because we were talking about the requirement of the patient. See, these are not normal patients. They cannot normally read some kind of size. So their requirement would be they have to read textbooks, they'll have to read Bible, they'll have to read Quran, they'll have to read newspapers, they'll have to check for the medical batch numbers. So according to each profession, each requirement would be different. So that each requirement has a different size. That is important. For example, see, the headlines of a newspaper are equivalent to N40 or N32, that is almost M5. Okay. Now when it comes to children's textbook size of children's textbook is N20, N16, N20 somewhere, that is equivalent to M2. Now the normal books are N10, newspapers and magazines are N8. Bible, the size of the Bible prints are N5. A pharmacist who has to check for the batch number and expiry date, it would be N5 or N4. So you need to know what are the print sizes of the common text that a patient has a requirement for. Okay. So these are the different near vision charts. Again, lighthouse chart we have for near also. These are single letter charts. Word charts are there, number charts are there. So these are, that game is the word chart. This is the number chart. Okay. Continuous text charts are there. That is, they'll be having lines, because not all low vision people can read continuously. So if the patient is able to spot the letters and words, then you also check for the continuous text. If continuous text reading is okay, then the patient has got a fluent reading skill. That is how you identify. Okay. So you have single letter charts, you have word charts, you have number charts, and you have continuous text charts for near. Like lighthouse, you have Bailey-Lowy charts. Words are there on the near vision charts. We have the M and N read chart. There, the chart has got both M notation and N notation. So you can know which line, which letter, which print size the patient is able to read now. Okay. Yeah. So once the visual acuity and refraction is done, you have tested the visual acuity, you have done the refraction by off-axis or radical retinoscopy, and you get the JND and you understand at least one line improvement with say plus 2.5, then that's okay. So you get the refraction done, and then you go for the further test. And after the visual acuity, second most important parameter is the visual field. Okay, visual field. For visual field, the peripheral field is tested by confrontation. How do you do a confrontation test? You know how do you do a confrontation test? Can any two of you come and demonstrate here? How a confrontation test is done? Anybody? Okay. So the second thing that we are going to do post lunch is a confrontation test. Okay, get ready by pairs. Definitely I'll call somebody and confrontation will be done. Okay, so, in the afternoon we have got some practical sessions. So confrontation is necessary. Then like the peripheral vision field is tested, you have a central field tested using a Amsler's chart. Amsler's chart, you have the central field tested. What is the degree that Amsler's grid tests? 19? 20. Okay, so this is how an AMSLS is reported by a patient. You can have macropsia, micropsia, okay? Yeah, metamorphopsia and scotoma. Okay, how you ask the patient to draw what amount of scotoma, how the scotoma is. What is scotoma? The invisible black portion is scotoma. So patient can see, you ask the patient to look at the central point and you ask to draw where the patient is seeing the black marks. So central field, you get a vague idea of how the patient is perceiving it. Okay? So visual acuity is done, field is done, then so this is the way you do a confrontation test. Then contrast. Okay, it is not like contrast is the different portion. Each and everything that you do for a low vision evaluation is different. Okay, then contrast is not a routine procedure, but in low vision contrast is definitely a mandate procedure that you have to conduct, because you need to know whether the patient's contrast is hampered, and accordingly you can think of the rehabilitation. So contrast, usually you do it with a FACT, that is functional acuity contrast tester there, or even Pelliropsin would be helping you out. Color vision chart, what is this test? This is D15, okay? And color matching is the usual process that can be done with a low vision patient. It is not that you, patient will be able to identify numbers and letters in color vision. So color matching is the usual process. So functional acuity is, functional vision is that you are assessing how much functional vision is present. Okay? Then contrast and glare, you can, glare, how do you test glare? Aberrometry, okay. How would you test glare for low vision patients? You take the patient outside to outdoors. Okay, outdoors and in different lighting environment, how the patient responds for the visual acuity, that is how you understand. Okay, in the normal room illumination, how the patient is responding. In dim illumination, how the patient is responding. Maybe the vision improves with dim illumination. You take the patient outdoors and then you test maybe the visual drops. You understand that glare is affecting. Okay, so when you understand that contrast and glare is affecting the patient, you can think of that in the rehabilitation. That is why contrast and glare is affected. It is not that you need to have the quantity of contrast, how much glare, that is not required. Whether it is hampered or not, that is what you have to know, that's all. Okay. See, talking about low vision, it is not at all about the quantity, it is about the quality. That's it. Low vision aids and technologies. Now that you have got a small amount of knowledge about what and all these problems are, what the patient is facing. Even when we talk about what the patient is facing, you need to know that, it is much beyond our imagination. What the patient has lost, it is much beyond our imagination. What the patient is seeing, it is much beyond that we can imagine. So, once the assessment is done, now you need to evaluate and you need to come up with how can you help this patient. It is not that normal glasses are going to help. We know that. Yes, standard refractive corrections are not going to do any good to the patient. When we are trying to do a low vision case, what are we trying to do? We are not going to improve the loss. What are you going to do? When you do a normal refraction, the patient reads 6/60 without glasses. You ask the patient to wear a glass or you give a correction and the vision is quantitatively improved to say 6/9 or 6/6. Quantitatively improved. But when you do a rehabilitation of a low vision, you're not actually improving anything. The lost is lost forever. What the patient has lost is lost. What you're doing, you're dealing with the residual vision. You're dealing with the residual vision. What is remaining? What is remaining is what you are trying to improve, not what is lost. We are not bothered. Now, when I show you a glass of water, or when I show you a bottle of water, what can you see? You see the major portion of the bottle is empty. Yes, that is one perspective. One perspective. Another perspective is the quarter portion of the bottle is filled. Okay? This perception is low vision. Patient has lost 70% of his vision. We are not bothered about that. Patient has got 30% remaining. We are bothered with that. Now, how can this 30%, how can this patient use his 30% for his daily living? How this 30% can he use for his mobility? How this 30% he can use so that he can cope up with a normal living? Rehabilitation is not making the patient normal. Rehabilitation is not making the patient normal. Rehabilitation is bringing the patient to near normal. Both are different. Okay, making a patient normal and making a patient near normal is different. Clear? So, you need to understand that the residual vision, only the residual vision is that what you have in your hands, and how do you enhance that? For enhancing, you have different methods. So just look into what are the low vision aids and technologies available. When you think about a low vision aid, you have to check for the patient's goal. What my patient wants. Okay, now I am trying to evaluate this patient and I am trying to give a softwares for reading. Is there a requirement of a spectacle magnifier then? No. It is not that you have to give a magnifier. It is only understand what the patient's requirement is. So patient-oriented approach is important. Okay, I have studied this. For ARMD, you have to give a spectacle magnifier, that is mandatory. No, it is not like that. You have to check for whether my patient requires this, whether there is a need for my patient. So your approach is a patient-oriented one. Patient-oriented approach is required. Then it is not, yes, of course, magnification is the sole principle. Magnification is the main principle of rehabilitation. But it is not like you give a bigger magnifier, bigger magnifier, bigger magnifier. No. Magnification should be comfortable. What are the problems with magnifiers? Higher the magnification, lesser is the field, and closer is the working distance. Okay, so the patient will have to hold it this way. So that is quite uncomfortable. So the magnification should be comfortable. Field of view, you have to check on the field of view. You have to check on the working distance. So all these things has to be considered. Then patient's occupation, patient's requirement, patient's physical ability, disability, everything has to be considered. Okay, a patient is not, a patient is an old patient, okay, and he has got tremors. Is there a point in giving a hand magnifier? Okay, so, according to the patient's physical ability, physical requirement, you have to choose the low vision aids. Okay. This principle should always be kept in mind. It is not that you jump on to the patient with a magnifier. Even before giving a magnification, you can always think of these three important principles, which of course works for majority of them. That is bigger, brighter, and bolder. You're not able to read normal Quran. What will you do? Ask the patient to have Quran with larger letters. Okay, that is one principle. I'm not able to read Quran at this distance. I'm not able to read Bible at this distance. Just hold it closer to your face. Okay? I'm not able to read it properly, I'm not able to read the newspaper properly. Think of adding an extra illumination while reading. Only that small changes can help the patient see better. So even before starting with magnifiers, you have to think of approach magnification, that is holding the things closer. When things are held closer, the image on the retina is put onto a larger area. So the undamaged retina could take up the image, and hence the patient will be able to see. Okay, some amount of retina is damaged, that is why he is not able to see. The central vision is lost or the peripheral vision is lost. But when you hold it closer, the image is put onto a larger amount of retina, where undamaged retina could take up the image. Okay, so this is very important. You can think of bigger, large printed textbooks. You can think of bold line notebooks, felt tipped pen. Okay, even before you start using magnifiers, these three actions are very, very important. And then you can think about low vision trials. Now, what are the low vision trials? We have optical aids, we have non-optical aids, we have electronic aids, we have assistive aids, we have so many things. See, now when you browse onto Google or something, there are devices which I cannot name itself. Such amount of technology has grown up for low vision and blind people. So that is the way. These magnifiers and telescopes and all these blah 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 things are outdated now. Now new technologies have come. How many of you have got mobile phone in your hands now? No. Just check for V-Zoom. V-Zoom. Check for V-Zoom now. What is V-Zoom? You know what is V-Zoom? Huh? Check for V-Zoom. V-Zoom is it's an application magnifier. Downloaded it? Just download it and see. Just download, not now, as your convenience. Okay? That is a very easy Android application that any people can have an access on. It's a free magnifier, see? You need not have to spend. You know what are the amounts, what are the rates of spectacle magnifiers and all these things? The minimum cost? The minimum? The least minimum? You know what is the amount? Almost above 800 and plus. Below 800 you can't give anything. You'll have to cut down on your profits then. Okay, so this is one small application that is available on your Android phones. So what I'm trying to tell is, more than these optical and non-optical devices, the electronic and digital devices have come up with so many things that can help a low vision people. So you have to be updated with it. These are some low vision devices. We all know the optical devices for near. I'll just read that out. We have spectacle magnifiers, we have handheld magnifiers, stand magnifiers, illuminated, non-illuminated. Then you have dome magnifiers, Fresnel book magnifiers, bar magnifiers, and so on for near. For distance, you have telescopes. Telescopes are the only magnifiers for distance. Then for non-optical devices, other than the lenses, which will help you to cope up with the glare and contrast, like visors, umbrellas, filters, then typoscope, signature guide, letter guide, needle threader, notex, so many things that will help you out to find things much easier. Okay, then you have other assistive devices, the electronic devices, the so-called electronic magnifiers, which will help you to see things bigger. Screen readers are there, JAWS softwares are there, so many other things. On the other hand, we have talking clocks, talking vessels, okay? So many other things, yeah. We'll have a low vision trial for distance. For distance, telescopes are the only magnifiers. Now, what amount of magnification is required for distance? How do you calculate that? How do you calculate the magnification for distance for a low vision trial? That is important. See, you have measured the visual acuity, you have done the refraction, that is it. Now you are trying to do a low vision trial. In order to do a low vision trial, you need to know what amount of magnification is required. How do you calculate that? You are with the answer? Okay. How do you calculate the magnification for distance? The denominator of best corrected visual acuity divided by denominator of target visual acuity gives you the magnification for distance. What is the patient's best corrected visual acuity with standard correction? And what is the required visual acuity, or what the patient requires? What is the target visual acuity? So you divide it and see, and that gives you the magnification, the amount of magnification. Okay? Now, magnification is always denoted by x. X notation, 1x, 2x, 3x, 4.5x, and so on. What does x means? 1x is equal to 4 diopters. Suppose you require a 10x magnification, 10x is equal to 40 diopters. Okay? Suppose the dioptric value of a lens is 32 diopters, what is the magnification? 8x. 8x, right? So, magnification is always denoted in x notation. That is important. So, this is the way you calculate the magnification. So, you know how much magnification is required for the patient. 4x is required, 2x is required, 3x is required. Then you go and think of that. You give a 1x, patient sees no. Then you give a 2x, patient sees no. You give a 3x, no. You should have a fixed calculation, and then you can go something lesser or more. That is okay, but you should have a plan of your magnification. Okay, so telescopes comes in different varieties. You have spectacle mounted telescopes. Okay, these are binocularly spectacle mounted telescopes. What is this? You have seen this? These are not spectacle mounted, these are called as bioptic telescopes. Bioptic telescopes are telescopes which simultaneously gives you near vision and distance vision. They have an automatic fixation on the telescope that is kept on the upper portion of the spectacle. This is the distance telescope, and through the near the patient can see the regular functioning. Okay, so these are called as bioptic telescopes. Then you have seen that? Those are called as, what is that called? That is also a telescope. You know that? They are called as CTV telescopes. CTV, not CCTV. CCTV is also a low vision aid, but this is CTV. CTV, it is basically a combination of two lenses. Two lenses are there. What is actually telescope made up of? Huh? Magnifier. Convex lens. What is telescope made up of? Best. Plus lens. Plus lens alone? Plus lens alone? Telescopes are of two kinds. Telescopes are of two kinds. Keplerian telescope and Galilean telescope. Galilean telescope is the usual low vision aid. Keplerian is also used, but Keplerian is a bit more heavier. So the regular ones are Galilean telescope. Galilean telescope is a combination of a concave lens at the eyepiece and a convex lens at the objective. Okay, Keplerian is a combination of two plus lenses, convex, but this is a Galilean telescope, minus, plus, minus near to the eye and plus. You can have it in the trial frame itself. You can hold a minus lens and a plus lens, and you can see that the distance things are viewed magnified. Have you done that? So that one is called as a CTV. These are all new devices. It is not that you always have that small binocular thing now. Everything has changed. Everything has changed. When you check into the new low vision trial, you get astonished to see that so much has been done for them. But only thing is the accessibility is lesser. Okay? So what the CTV is, CTV has got a manual adjustment knob here on the temple, and the patient can adjust and view the distance. That's it. This is an automatic system, but here it is a manual system. Okay. Then the regular one, we have handheld monocular telescope, handheld binocular telescope, spectacle mounted monocular telescope, spectacle mounted binocular telescope. All those are there. So these are handheld monocular, spectacle mounted binocular, that is CTV. These are all regular ones. CTV. Okay. So these are the trials for distance. Telescopes are the only aids that you give for distance, but it is not that easy. Why? Because using a telescope, you require some familiarization. Patient needs to know how to use a telescope, okay? And then simply by just putting it in front of your eyes won't do anything. Patient and the object to be viewed both should be stationary. It is not like you are moving and you can use a telescope. No, the observer has to be stationary, the object has to be stationary. You should have a good central field. Only then you can try for telescopes. And once telescopes are given for trial, you have to locate, position, check for what object I have to see, and then what you have to do, you have to fixate that object, then focus the object according to the distance, okay, and then spot it, track it, trace it and track it, and then scan and move. That is how you do a telescope viewing. Okay? So that is how a telescope is trained actually. It is a device for low vision, okay, for macular degeneration and even for blindness, where the patient is able to see what is in front of him. Okay, so he can perceive it in the screen within that device, inox. What is that? The picture is not clear, I guess. Huh? Reading newspaper, but it is using a device. That is called as a headband magnifier. A band is kept over the head and there is a magnifier here. Why? Because it looks very awkward. But it is very easier. Because you need not have to bend this way. Usually with magnifier you will have to bend towards closer to the object. With this you need not bend. You can have an erect position, but then you have to hang it over your neck. People don't usually accept it. So, spectacle magnifiers, stand magnifiers, dome, everything, I think you have seen it. We'll have it in the afternoon, normal session, where I'll help you out how to use this, how train the patient and things like that. Beyond the optical devices, other than magnification, you do something to enhance the contrast and the glare. Such devices which help you enhance the contrast and glare are called as non-optical devices. Starting from the visors, the simple peaked caps, the simplest device that you can give to help your patient avoid glare is a peaked cap, umbrella. Okay? Starting from those such devices, all these are meant to be non-optical devices. What is this? Writing guide typoscope. You have the filters which will help you out to clear the glare. What are these? Talking thermometers. Okay? Yes, signature guides, check guides, no-tex, and things like that. Okay. So these are some non-optical devices which help you to enhance the contrast and eliminate glare. Now talking about the assistive devices. Assistive devices are beyond what I can mention, beyond my knowledge, because even I am not updated with what is the newest thing that has been developed for low vision. You have electronic magnifiers, mouse magnifiers, book magnifiers, then you have talking softwares where the magnified text could be read aloud with certain softwares. I have a neighbor named Abdullah who is blind by birth, but he is a famous person now. How he has been born and brought up is he almost lives like a normal child. He has a twin brother with full vision. So I'll just give you an example. They live very close to my house. Few years back, when they were studying in some ninth standard or something, now both of them have completed degree, and Abdullah is doing his post-graduation, and his brother is working abroad. In front of my house is a mosque, and there is a big clash going on between these two brothers. So I just came out and I asked, what's the problem? Why Abdullah, why are you fighting with Abdurrahman? What is the problem? So it is night time, and they don't have a torch to go. So they have to pass a playground. A playground is there in between both of our houses. Once they pass the playground, the next house is theirs. But when they pass the playground, the path is very small, that there is a depression next to that ground. Okay? You're understanding? It's a college. So beyond that, you can fall down. So it is such a restricted path. So only with light you can move there. So what is the fight is, Abdullah wants to walk, but Abdurrahman is not ready. Why? Abdullah is blind, Abdurrahman has vision. He cannot walk in darkness. But Abdullah lives in dark. He has no problem. He knows how to walk, and he wants his brother to come along with him. But the brother does not have the confidence to move with Abdullah because it is fully dark. So that was the fight. Finally, what happened? I convinced Abdurrahman to just go with him and check what will happen. And then finally, Abdurrahman walks like this, because he is very afraid he'll fall down. And Abdullah was very coolly walking, because he knows how it has been for him years. And finally, they reached home safely. Abdullah took him. That is the difference between a blind and a normal person. Okay? Darkness can hit us, but darkness won't hit them. So what I was trying to tell is, assistive devices, actually you should meet Abdullah to know what are the newest technologies. He sends me, I don't want you to mock at me, okay? He will help you out to know what are the newest assistive technologies. He sends me message through WhatsApp. He stays on Facebook Lives. Everything is possible because such amount of development has come up in the assistive technologies. Okay? So this is a reading software that the child is using. Even if the child is not able to see what is there on the screen, the child can listen to what is there on the screen. This is a normal electronic magnifier. Electronic magnifier you can have in different ways, starting from mouse magnifiers. Only thing is, what you want to read, you keep it just below the magnifier, and it gets magnified onto the screen and you read it. Okay? buying some low vision aids, giving some magnifiers, giving some spectacle magnifiers. Yes, this is enough for you. You can go and come back after 3 months. No. This is not simply listening to a rubbish class and talking. It is beyond what you think of how to deal with a low vision patient. And if you're not serious about this, there is no point in sitting also. Okay? So a provision of a low vision device, then thinking about contrast enhancement, how you can improve the contrast, how glare can be avoided, how lighting, in some cases additional light will help to see better. Sometimes additional lighting will reduce the vision. So you need to understand what lighting modifications are required. Sometimes you will have to give an eccentric viewing training. What is eccentric viewing? You will be explaining to me in the afternoon. Then orientation and mobility training is given. Training for employment. These people cannot do normal routine jobs. So with this vision, with this amount of functionality, what kind of job you can choose, you help them, you counsel them to get a better job, things and all. Then the daily living activities are enhanced with assistance. Counseling are done because psychosocial impacts are there. If person sticks on to depression, you will have to counsel them back to normal living. If the patient is stick on to anger, you will have to counsel them back. So counseling is important. Then you have to tell them about the eligibilities, about the concessions they can avail, the government concessions that is available for low vision and blind people. So all these together is what comprehensive low vision is. It is not simply you measure the visual acuity, calculate the magnification and give a low vision device. No, it is beyond giving a low vision device. So this is what a worksheet looks like. We'll be talking about that in the afternoon. Yes. So now we are breaking for lunch. Sight is next to life. We all have to think about how to protect it. Not talking about the normal visual disorders. We are talking about the low vision category where they have to live on their entire life with only some little vision. Literally no vision. Okay, think of a child who is born with a congenital disorder where the child is not able to perceive color, where the child is not able to identify his mother's face. He has to live long with that condition. Can you make that child sit at home without any education? Can you make that child move out independently? That depends on how you take up the condition. Okay? So all the best. In the afternoon, we'll be having 2 to 3 case studies and how you deal with cases, how you work out cases, and that's the end of the session. Thank you. was the patient's complaint? What would be his complaint? He will not say, I am not able to see. He will tell you specifically that I am not able to read textbook. I am not able to see the blackboard. I am not able to write down my accounts. These were the few complaints that I had faced. Complaints. What we usually say is, I am not able to see. So their complaint will be beyond that. They'll tell it. Okay. Then you can have a bit of the family history, for example, like glaucoma or something like that, diabetic retinopathy. You can also ask if any of his parents or any of his spouse are undergoing the same condition. Do they have any problem? So most probably it could be a yes or whatever. So you can just write down if is there anybody else who is undergoing the same condition at their home. Then parental consanguinity. Very important. Genetical counseling is important, where parents are blood related or not. Then, do they have any ocular conditions? Do they have any problem? Then you have to specify that. General health of the patient, is the patient otherwise normal? Or the patient has got some other conditions as well associated to it. Any you can have like any paralysis or any general disease condition along with this ocular conditions that has to be written. You can just write down about the external observation of the patient, how the patient walked in, patient had a eccentric viewing, or patient had a face turn or something like that. That can be there, and any other general limitations, any other disability you have seen with the patient is not able to walk or something like that, then you can just write that difficulty in walking, the patient has got any tremor, patient has got a hearing loss or any other multiple disabilities. So all these conditions has to be noted down. You can write about the patient's occupation, what the patient currently is doing or what the patient had been doing, was a teacher or was a farmer or whatever. The patient's occupation is important. Then is the patient married or is he living alone? How many children? What about his spouse, his wife, or her husband? Whatever, you can just have a mentioning about. So this assessment form is going to give you a detailed picture of how the patient has a social living. Okay, so everything is important. Then who takes care of the patient? If the patient is an old man, who takes care? Maybe his wife or his daughter or his son or his daughter-in-law, maybe husband would be taking care, or maybe mother is taking care of the person. So who is a caregiver? That is important because you need to counsel them also regarding the conditions and regarding how the patient sees and see. Now we are going into detail, the second page of the assessment form. Previously, has a patient used any low vision device? Was a patient using any low vision device? Yes or no? Maybe he has used or he has lost the hope. He might not have used it properly, or he might not have been given a proper counseling regarding the usage of the low vision device. So you need to know whether the patient had a previous history of low vision care. Was it self-purchased? Sometimes like people, you can see people wearing reading glasses where they have bought it for their own, like we buy watch or something else, they'll have a reading glass for their own. Okay, a 45-year-old person wearing a 2.5 add power, because 2.5 add power, it is looking bigger, so I thought this is good. So sometimes low vision people might have used low vision device for their own. They might have purchased it self, or it would have been prescribed by somebody, so that also should be mentioned. What kind of optical device was used? Was it a telescope, a monocular telescope or a binocular telescope? Was it used for near, any handheld magnifier, anything was used, stat magnifier was used? Any non-optical devices were used previously, that is important. How long has the patient been using this? For what purpose was that patient using this? For reading alone, for writing, for viewing blackboard, that is important. How much time did he use every day? Only during class hours, only during traveling outside? Was there any difficulty using that device? What are we talking about now? We are talking about the previous used low vision device. Previously used low vision device, we are taking a history. Was there any difficulty? And if yes, what were the difficulties? What kind of difficulty does the patient have? Now we are dealing with the current status. Okay? Currently, what is the patient's problem? This is task related history. You see, task, you need to ask everything. Ask them, do you have a problem seeing the blackboard? There is no point in asking this to a 65-year-old man. Understanding? Okay? You have to ask everything, but ask sensibly. Okay, is there a problem seeing the blackboard? Do you have a problem recognizing faces? Do you have a problem watching TV? Do you have a problem watching the bus boards, bus numbers, seeing the traffic lights, seeing street lights, everything that is happening at the intermediate and distance, okay? Crossing roads, do you have problem while driving, getting around people, seeing steps? Do you have any problem walking down the steps, taking the steps and like that? Such all things should be asked properly, and if at all you have, you can just round that or underline that. If the patient has a problem in watching TV, you can underline that so that you understand. If the patient has a problem in recognizing faces, you can underline that. Now coming to the near difficulty, what and all difficulty does the patient have? First thing, do you have any problem with the near? No, I can manage near, distance is problem. So you need not bother about near then. Okay, if the patient has got a near difficulty, what kind of near difficulty? Reading college books, reading school books, office books, regular print books, newspapers, devotional books, computer prints, office related materials, using a mobile or price tags, bill, medicine labs, expiry date, handwritten materials. What kind of near vision problem do you have? And what and all he is telling, you can just mark it, so that you can calculate the EVP for each requirement. EVP for each requirement. The EVP for a college book and EVP for a medicine label would be different. So you need to know what my patient's requirement is. My patient does not want to read a medicine label, then I need not magnify it for the N5. Understanding? So that is important. Now, does the difficulty reduce when you are taking the reading material closer? Bigger, brighter, bolder. So you ask, do you do anything to help it out? Do you place the material closer? Do you use any additional lighting? Does the difficulty reduce when there is good or increased lighting? When there is an additional light, does it help you? No. It actually creates much problem when I use lighting. Sometimes they say yes, when I read under lighting, then it is fine, yes. So you get the mentioning about the lighting conditions, the glare, the contrast and everything. And you can actually ask them, is reading a priority for you? Do you actually have to read a longer time? Is it necessary that you need to read? What reading do you want? Do you want to read academic, or do you want any educational purposes or for any occupational purpose or just for pleasure or for information? Sometimes you may have a person who has to detect numbers from a directory. So is it a prolonged work with directory? No, it is just a spotting. So what kind of reading, how long do you read, everything is required. So this is what we call as a task related history. Not only about writing, not only about reading do we ask about writing as well. Are you able to write in a straight line? Okay, are you able to write, sign checkbooks? Can you write your office papers, sign office papers? And sometimes for mothers and all, we ask if you go to bank or if you go to your school, your child's school, can you put the signature in the right box? Are you able to see everything? Are you able to write in a straight line? Can you write it for a longer period? And such like of things. Then, of course, difficulty with digital problems like computers and mobiles has to be asked nowadays. Do you have a problem working with computer? Computer is actually an intermediate vision. We have talked about distance, we have talked about near. Now we are going to talk about intermediate. So is there a difficulty with computer? If yes, is there a problem in seeing the keyboard or watching the screen or reading? What is your problem with the computer? That has to be mentioned. So we have taken a task related history for distance, for near, for intermediate. Now we ask about mobility, movement. Can you move independently? Do you attend marriage functions at your hometowns? Do you go for regular shoppings? So such kind of things we ask questions. Do you use cane or any assistant? Is there anybody who accommodates you while going out? Recently I had a person, he has got RP, retinitis pigmentosa. Just few weeks back, he came to my new clinic, and I don't have a rehabilitation at my new clinic, so I had advised him to come to my older one. I was actually shocked listening to his history. He had a vision less than 1/60, and retinitis pigmentosa, you don't expect much improvement in the distance visual acuity. So I asked him, whenever you go out, please do take somebody, some companion along with you. He didn't have children. So I asked either your wife or your friend, somebody should definitely accompany you, especially in the evening. Especially in the evening, please don't go out. He told, I go everywhere. I move very independently. I don't have a problem in moving around. I was like, how does he manage it? I don't know, he has got a visual acuity less than 1/60, but he still manages. And his wife was telling, I always tell him that don't go out in the evening, but he wants moving out and he goes alone. And he comes back after 8 o'clock because he loves sitting at the roadsides in the evening. So that is his leisure time. He spends out evenings in the roadside, and I always ask him, don't go out in the evening because it is difficult for you to see. And wife is telling that he sometimes has to just, on the table, if there is something, he'll have to just drag his hands and check for is there anything. And how such a person moves out. So that is the perception of life that each one of us take differently. Okay, now he could have sat back at his home with just 1/60 vision, but now that is his leisure time. He enjoys sitting at the roadside. He literally sees nothing actually. What he can see is, he will only listen to some horns. He can have some breeze coming in. One vehicle is going this way, that way, nothing else. But then still he enjoys that evening, the evening vibe. So that's it. That is what I meant is, the issue of mobility is personal. The issue of mobility is personal. You may feel how this person is walking, but I have just recently met a person with RP who manages himself doing everything. He even goes for his job actually. So that is different from person to person. Regarding mobility, usually people will be happy and comfortable at their home because they know where each furniture is placed, how each room is arranged. He knows that he has to go and sit here. But in an unfamiliar place, it will be difficult. Unfamiliar place, he doesn't know. So he may bump into objects. He may need a person along with him. He doesn't know where the step is. At home, he knows that the 11th step is a floor. So he knows that 11th step I can walk smoothly. That is different. Okay. So you can ask him, do you have a problem at the staircase? Do you have problem with familiar places? Do you have problem at unfamiliar places? Do you bump into objects? Okay, you don't know where things are and you just fall down or you hit with things. So all such things has to be asked. You know why I asked all these questions, and that is why that old man, he shouted at me. Okay, because this sometimes is very, like, you have to say, yes, I have a problem. Yes, yes, I can't do that. Yes, I can't do that. Yes, I can't do that. Yes, I can do that. So everything you trigger him that he doesn't know, he's not able to do things. So that triggers his anger. That is right. I remember I asked something like this only. Do you go outside for marriages or something like that? I reached that question and he shouted at me. I still remember. Years back, but I still remember the situation. I was standing in front of him, helpless, didn't know what to answer. But still understand the psychological aspect of a low vision patient. Then talking about the daily living activities, the routine procedures of our life that, see, look at the questions. Can you take baths for yourself? Okay. You can't see the soap, you can't see the bucket, the mug. You don't know whether the bucket is full of water. You don't know whether there is no water in the bucket. Understanding? Can you assume what is happening with the vision? So you ask whether the patient can take a bath on his own. Can he do his cooking? Can she do his cooking? Can she manage her cooking by herself like she did earlier? Dressing up. Okay, dressing up means there are so many things when we do a makeup, right? Where vision is very, very important. For example, putting an eyeliner. Is that easy? That isn't easy. You have to look this way, right? Huh? Putting a lipstick, is that easy? No, you have to check for your lip borders and all. Okay. When I attended a low vision training at Bombay Lotus College of Optometry, a low vision person herself had come for the class just to show that what a low vision person can do. And I was really shocked with her. She was amazing. So after this session, she literally couldn't see anything. She was using an iPad, and that had a software, and with that she was able to take classes. She was an extraordinary person, but what I am trying to tell is, after the class I went and I just hugged her to get that warmth or make her understand that how appreciating I am. Because she won't look at my facial expression. She can't see this. Okay, so only touch can be felt. So I just went and hugged her. She was very happy actually. She was old enough. I hugged her, and when I looked at her, when I was seeing her as an audience, she was very beautiful. She's actually very beautiful. And when I saw her very close, I could see that her lipstick was above the lip border. Her mascara wasn't clearly put, but she had managed doing everything. So the way they cope up with life is different. For us, we check for all the lines, the the contouring, everything is done. They also do it, but there will be some problem with them, but hence they'll actually try to cope up with their life. So dressing up, stitching, putting on makeups, doing embroidery works, doing normal household. Can you sweep your home? Can you wipe? Can you do the floorings? Everything is important. Asking each and every question is important. What about your personal hygiene? Can you see your nails are grown? Can you take off the dirt from the nails? Everything is important. You see that. Threading a needle, identification of currency, coins, seeing the food on the table, color perception, identifying objects on the floor. All small things has to be identified. Once all these questions have been asked, now you ask them what their expectation is. Expectation in the sense, what does the patient want importantly? Yes, the patient can't read, patient can't write, patient can't move, everything is okay. But there would be some few things that which is very important for the patient. I have to read. For any reason, I can't quit reading. Reading is my passion. I have to read. So then definitely you have to give reading as a priority. If the patient says reading, I can manage with audiobooks. Reading is not necessary for me, but I need to write. That is important. Okay. So this is how you prioritize things. Okay. You can also ask about if this is a child. Okay. This is a child, student, you can go for an additional task related history. You can ask the standard and school of the child, which school is he studying, regular school or special school, his name of the school, his teacher's name, class teacher's name, how many students are sitting, where does he sit in the class, his seating position, his distance from the board, which bench, which row, where is the window, where is the door of the child. Everything is important. Where actually the child is seated in the classroom. Then his academic performance, how well he does he get good marks, what grades did he get in the previous examination, how good he is with his friends, does he have friends. Sometimes child may be he may be learning in a normal school, but he may not have friends. Why? Because unlike others, he is not able to play in the playground. Unlike others, he is not able to play some good games that usually children play. So he is not fit into that peer group. So that's why he may not have good relation, or good peer group may not be there. So that is important to understand how social the child is. Okay. Then regarding the parent-teacher relationship, are the parents and teachers in good relation? Do they know about each other and things? That is important. Okay, and how does a child see from the blackboard? Sometimes a child does not see from the blackboard. He may be copying it from his friend's notebook. So how he takes up his notes and all, everything you have to ask. These questions are especially for students. Okay. Now, if at all the child is in a special school, does he use a braille system, or does he use normal bold line notebooks and large printed textbooks, and such things are used. Sometimes audio books are used. Nowadays, every special school, they have got audio books. So they can listen to every textbook that a normal child studies in a normal schooling. And you can ask, is the teacher cooperative and ready to give individual attention? If yes, the teacher has to be counseled. Actually, low vision rehabilitator goes to the child's classroom. He goes to the child's classroom. He sees how the child sits. Sometimes a child may have a problem with the glare, so the child should be shifted away from the window. Okay, sometimes approach magnification would do good, so the child will have to sit just near the blackboard. Separately, individually, the child is kept to sit in front of the classroom. But teachers and management of the school should be cooperative enough to have a classroom modification. Understanding, everything is done by a rehabilitator like us. Okay, so is the school management ready to make changes? Is the teacher ready to make changes? If yes, you first give a letter and then you go by person. You go home. You check for the environmental modification of the child at the home, how house and all can be changed according to the lighting conditions, according to contrast and things like that. Okay, so this is how general low vision form task related history looks. After this, what you do is you calculate the magnification. Then you do a low vision trial, and then you check whether this is good for the patient, which is good for the patient. 2x magnification, spectacle is doing good, or handheld is doing good, or stand is doing good. 2x you can have spectacle and stand and hand, but you don't give everything. You give only one or two. Maybe one for reading, prolonged reading, one for writing. What are the good things about Ashwati, can we have the low vision kit? Yeah. Has everybody seen low vision devices? Low vision devices? Yes. How many of you have not seen low vision devices? Everybody has seen. Okay. So one by one we'll just check now how to use each low vision device, at least available things, how do you use it. So the very common low vision devices, the very common one, spectacle magnifiers. Very common one, and the first choice is spectacle magnifiers. So these are the spectacle magnifiers. Okay? They come in prismatic and non-prismatic spectacle magnifiers. If the spectacle power is above 4 to 5 diopters, spectacle power is above 4 to 5 diopters, prism has to be incorporated in order to, why prism is incorporated? Why is prism incorporated above 4 diopters? In order to maintain binocularity. In order to maintain binocularity. If the power is above 4 or 5 diopters, it will be highly magnified and binocularity will be lost. So in order to maintain the binocularity, prism is incorporated. So spectacles above 4 to 5 diopters, you usually have prismatic spectacles. Prismatic spectacles. Have you ever worn a spectacle? Spectacle magnifier? No? Just try it. Just try it. How you see it? How you see with it? How do you keep it? You keep it over your face. I can't see anything. Why? Why this is meant for? This is meant for near. There is no point in looking at you then. Okay? So I need to have a reading material. When I get can I read this? Okay? So, see, here I can't see anything. I can't see anything. Higher the magnification, closer is the working distance. So this is the way I have to read. See, Indian Academy. And I cannot see everything. I cannot see everything in one single look. I have to sweep my vision. You seeing it? That is why I am asking you to use this thing. When you yourself don't want to use what this looks like, how will you rehabilitate a person with low vision? If you yourself feel this is cosmetically unappealing, oh, I cannot wear this, then how can you suggest your patient to use this? Understanding? And please don't be under the false impression that if you use a magnifier, God will make you use a magnifier at any time. I am afraid. There is no point. See, you just walk, you fall down, something hits onto your eyes, you have a corneal infection, you have a corneal ulcer, you go a corneal blind. Understanding? I and you can change a low vision or a blind at any moment of time if the God has decided. Understanding? So be thankful for what you have and try to understand what the problem they undergo. Okay? What I see in the crowd is majority of you are not, you have come on for a low vision session, but actually you are not motivated enough to work on a low vision. You are not at all motivated to work on a low vision. Okay? Yes. So, spectacle magnifiers are the easiest thing that you can give to a patient, the easiest device that a patient can use, because hands are free, patient can read and write with magnifiers, with spectacle magnifiers. Only thing is, according to the magnification, according to the power, patient has to bend down, or they have to bring the object closer for reading and writing. So with very close distance, writing is difficult. That's it. Okay. The maximum amount that you get with a spectacle magnifier is 24 diopters. Okay. I have a 10 diopter spectacle magnifier. 10 diopter spectacle magnifier. Can you please tell me what the magnification is and where the working distance would be? Yes, anybody? I'll ask. I will ask. You have marked? You have calculated 10 diopter spectacle. What is the working distance and what is the magnification? Yes. How did you get that? Shh, I'm asking her, no? She's ready to answer, then why don't you want her to answer? Come on. What is 10 by 4? Where is this 4 from? Where did you get this 4 from? Why didn't you divide 10 by 5? 10 by 5 is easier. 2. What is 4? 1x is equal to 4 diopters. So, in order to get the magnification, you divide the diopter by 4. 10 by 4 is 2.5x. So, a 10 diopter spectacle magnification is 2.5x. Okay? 2.5x. Now, what is the working distance? At what distance can you use this spectacle magnifier? Any more spectacle magnifiers? Here, there, there. Used it? Saw? 10 diopters working distance. Where is the working distance? Where is the working distance? How did you get that? 100 divided by diopters. That is the working distance. 100 divided by diopters, you will get it in centimeters. So 100 divided by 10 is 10 centimeters. That means you have to hold the object at 10 centimeters. Where is 10 centimeters? It will be somewhere very close here. So if you hold the material here, then you will be able to read with a 10 diopter spectacle magnifier. Understanding? Okay. So that's it. When you prescribe a spectacle magnifier, you have to definitely tell the patient regarding the working distance. How near will you be able to see? You have to hold it this way. Only at this distance you will be able to see. And then you have to think of additional illumination if the patient has got a decreased contrast. Okay, additional lighting will help you to see better. Clear? That is how you train a spectacle magnifier. Then the next thing, you can use a stand magnifier. Sorry, handheld magnifier. Stand, hand, both equal. What is this? Handheld magnifier. Okay? Usually handheld magnifiers, they have similar kind of magnification and things like we have calculated for spectacle magnifiers. how do you use a handheld magnifiers? How do you use this? How do you use this? Should you go closer or should magnifier go closer? Magnify go closer. Okay. You go closer. Magnifier go closer. Can anybody show me how a handheld magnifier is used? Have you seen? Okay. See this way. How you have to ask is, keep the magnifier on the reading material and then ask the patient to check for the better eye. Better eye could be right eye or left eye. So you have to check with your better eye. And then you move the magnifier from the reading material till you are able to see it good. When will you be able to see it good? When the reading material is at the focal length. Suppose the magnifier is 10 diopters. Where is the focal length? 10 centimeters. So, instead of keeping the material at 10 centimeters, the best way is you keep the magnifier over the reading material and you move the magnifier above till you are able to see. And you have to maintain this distance. Maintaining this distance for long is very difficult. That is why handheld magnifiers have higher magnification, but prolonged reading is difficult. Handheld magnifier, you can have both illuminated and non-illuminated. Okay? This is an illuminated type of handheld magnifier. Illuminated type of handheld magnifier. Getting? And you have to view a bit closer. View uniocularly. Binoculars handheld you won't get. Binocularly you won't get the axis. Uniocularly you observe where the magnification is and it is done. Okay? Handheld magnifiers are available in varied ranges. You can also get pocket magnifiers where the magnifier is kept bent into a box and then you keep it inside your pocket. You can take it at any time and you can spot it. So handheld magnifiers are very good at higher magnification, but prolonged reading is not possible. And people who are having tremors, shivering hands, old age group cannot use handheld magnifiers. Handheld magnifiers are meant to you see smaller size for spotting. Prolonged reading is not possible because you have to maintain that distance, and that is not possible even with us. Even with us it is not possible. Okay? Handheld magnifiers, different kind of handheld magnifiers are available. Okay? These are all handheld magnifiers, illuminated ones, illuminated handheld magnifiers. Illuminated handheld magnifiers. Okay? You don't give it to, off the light. I had a patient from Kannur. His name was Abu Bakr. He might still remember me because my name is Juberia and his daughter's name was Juberia. Yeah, truly. And he had kept me calling for several years then. Now he might have forgotten me, probably, I don't know. What his problem was, he was a coconut dealer at Kannur. He wanted to see newspaper. He wanted to see newspaper and he wanted to see his accounts balance sheet. That was his requirement, nothing else. He could read Quran with larger prints. He could do everything else. He managed doing everything else. His vision was very less. He was a diabetic retinopathy patient. And he knew his prognosis also that the vision is going to deteriorate than he had at that time. So according to the calculation, his requirement was newspaper. Okay, newspaper print. So what would be the target visual acuity? Target visual acuity. Target visual acuity. Target visual acuity. Target visual acuity. Target visual acuity is N8. Why N4? Fluent reading, you have to reserve 3 lines. 3 lines are reserved in order to have a fluent reading. But I took the target as N8 itself. You know why? His only requirement was to check the rate of cognate every day. Only spotting. So, you have to make sure what the requirement is. Spotting, so he told me, I just want, because my accounts people always, they cheat me, I just want to check the accounts. I just want to check the accounts. What is the rate? Every day, the rate I have to check in the newspaper. So, spotting itself is enough. I had given him a handheld magnifier. Handheld magnifier, because spot was enough for him. So, it varies from person to person. Nothing else did I give. He didn't want a spectacle magnifier. He didn't want a prolonged reading. Everything else he was managing by himself. So, only requirement he had was he wanted to check his account sheet because his staff was cheating him. And he was happy because he could find out what the problem was. And then regularly in 2 weeks or 3 weeks, he will call me. How are you? You're fine. Juberia here also. She is fine. How are you doing? That is the kind of relation you build with your patients. Not all patients call you back home. Do they? No. So that is the love and energy you get from your patients. Okay, so that is about handheld magnifiers. Then we'll talk about stand magnifiers. Okay? Stand magnifiers or handheld magnifiers all come together. Only thing is stand magnifiers have a fixed working distance, fixed focal length. So only thing is you have to keep it over and then you have to move towards the magnifier. This is the way you use stand magnifiers. You have to move to the magnifier because stand magnifier has got a fixed distance. So along with stand magnifier, you always give a reading stand. Reading stand is given with a stand magnifier so that, do you have a reading stand? No. Reading stand is something like this. You will have a stand. You will have a stand like this. Okay, a wooden stand. You can make it also with a plywood because that is costly when you take it from a low vision rehabilitator. So you ask the patient to make it out of a plywood so that is kept slanting and you go like this. Otherwise, if it is on the table, you have to go like this. On the slanting table, you will have to just move like this. So this is better. Prolonged reading is the best part that you can do with a stand magnifier. Prolonged reading. Stand magnifier comes out of with illumination, without illumination. Okay? And then you remember the cutaway stand magnifiers with which you can write as well. Write as well. Okay? With handheld magnifiers and stand magnifiers, you can't actually write. It is only meant for reading purpose. Understanding? No? Okay? Then you get larger magnification with things like dome magnifier and bar magnifier. Only meant for reading, no writing purpose is done. Okay? Larger magnification with dome magnifier and bar magnifiers. Then again, a complete sheet, complete page is magnified using this. This is called as a Fresnel sheet magnifier. Fresnel book magnifier, Fresnel sheet magnifier. You place it over and then you find this is magnified. Okay, that is the way. Magnification is less, but together you can see the page is larger. People with good vision can use this. But I usually don't suggest this thing. Okay, what is Fresnel? Scratch, not scratch. What is Fresnel basically? It is not lines, these are stacked lenses. Stacked lenses. So, the scattering of light is more. We can see, but people with scotomas and people with decreased contrast, they'll have problem with Fresnel magnifiers. Magnification is much lesser. You can see this. Magnification is much less with Fresnel. Only thing is, all together you can see at a time. Okay? So understanding? ഇവിടെ പൊട്ടിപ്പോയതോ. See, this is how a cutaway stand magnifier is. Okay, you can just see if you can write. Prolonged writing cannot be possible, but then still you can simply sign or do some markings. Okay? Yeah. This Fresnel book magnifier comes as a neckband. This will have a neckband here, and you can read it this way. See, I can see everything bigger. Floor is bit larger. Okay? You can have it as headband also. Over the head, you will have a band over the head, and then you can, so that you don't use, your hands are free. Your hands are free. When you keep it over the neck, your hands are free. That's it. Coming to yes, Fresnel. Coming to telescopes. These are monocular handheld telescopes. You can have monocular spectacle mounted telescopes. You can have handheld binocular telescopes. You can have spectacle mounted binocular telescopes. You can have bioptic telescopes. When I tell all these things, do you remember the picture I showed you? Okay? So this is a handheld monocular telescope. How you use it is, So these are the few optical devices that you can regularly have it, and you know how to calculate the magnification for telescope. You know how to calculate the magnification for near. Near you know. Distance, why you don't know? We'll know now whether you know or you don't know. Okay? Now, coming to non-optical devices. Non-optical devices, these are reading and writing guides called as typoscope. You keep it, whatever you have to write, you keep it inside, and then what are these things? These basically enhance contrast. Contrast is enhanced. When then these black lines are seen, you know that you have to write over this. So writing on straight line, we ask the child whether you can write in a straight line. Do you have any difficulty in writing straight lines? So do you have any difficulty reading your textbooks? If yes, you can place this over your textbook, and then the child can read line by line by line. Okay? So these are basically contrast enhancers, typoscope. Same way, what is this? These are check guides, signature guides. You can place it where you have to write your name, where you have to put your signature, that box, over that box you can place this, and then you have to write it within. Sometimes I have seen people just tracking this way, this is the space, and then they write their signature. Okay? These are signature guides and check guides. See? This is a check guide. Check guide, you put your date, you write the amount here in numbers, here in words, you put your signature. So this is a perfect check guide. This is Notex. Notex, not now. Notex, old Notex. Notex means identifying currency. Okay? The older, you remember the old notes? Before 2016? Okay? We had notes for 1,000, 2,000, 5,000, 6,000? No. Remember the older notes for 50, 100, then 500, 1,000, right? So those could be identified here. 1,000 was the only note where you can have a feel here. You place it over the note. You have an old 100 rupee. Over the Notex like this. So 10 would be here, 20 would be here, 1,000 was the only note, you can feel it here. That was the old system. You don't have a Notex for the current currency. Okay. So people feel it here on which step it is. Yes, 50, 100, 500, 1,000. That way people used to identify the note. Okay. Similarly, you can make check guides, signature guides. You can always keep this in your pocket wherever you are asked to sign. In a PTA meeting, your mother goes and she is asked to put a signature. She can place it over there, and then she can feel the space, and there she can put the signature. That is how you use such things. Okay. What we are trying to do is, we are improving the functionality of the residual vision. Functionality is being improved, not the vision is not improved. Understanding? Yes. Okay. So this is the way evaluate and assess a low vision case, and then you calculate the magnification, and then you give a trial. Sometimes you know that spectacle magnifiers are good, but sometimes spectacle magnifiers won't work for the patient. Then you have to switch to stand magnifiers or handheld magnifiers according to the patient's requirement. Sometimes you will have to give more than one. One for writing, sometimes you give a spectacle magnifier for writing and you give a stand magnifier for reading. Okay? Sometimes you give 2 or 3 additional optical aids along with non-optical aids. So this is a comprehensive approach, not only just one device. Like patient has come for a refractive error problem, you give one spectacle and you leave the patient. It is not the same way. You have to give a bag full of things to make his life easier. Okay? Sometimes you will have to go along with him to make some changes at his home. Okay, like some contrast enhancement. How do you do a contrast enhancement? How do you do a contrast enhancement? This is a low contrast environment. Why? Because the door and the wall both are of the same color. Okay, as far as a low vision patient is concerned, he won't identify there is a door here. So for him, what you will have to do is, you will have to give a darker border here to make him understand that there is a door here. Okay? We have all the steps of the same color at our home, but a patient, a person who is living with a low vision, you will have to mark some borders at least at the last step, telling that this is the last step and next is the floor. So you have to walk like this. Okay? You can give handrails over the wall so that the child or the patient can hold the handrails and then walk each step. And ask the people in the house not to move things here and there, because they might have adapted themselves to a condition of the placement of objects. So when you move something, they can't adjust to it very easily. They will adjust it later on, but not. So such environmental modifications, such modifications in the classroom, glare problem, ask the child to sit away from the window, make the child sit near to the classroom. So low vision rehabilitation is not simply happening at the optometry table. You have to go out with the child, move out with the child. Non-optical devices, you have filters. Okay? So filters, you ask the child what are the regular routine activities he does. I go out to play at 4 o'clock. So you have to go with this child at 4 o'clock where this child plays. I'm not joking, really. And at that 4 o'clock time, what lighting condition is there, you check each filter. If the patient is okay with it, is this okay? Can you play cricket? Can you see things? Yes, I'm okay. Maybe 1 or 2 additional filters you will have to give. Sometimes a brown or grey filter for outdoor. Sometimes a pink filter for inside. A yellow filter during night. 1 or 2 additional filters you will have to give for patients like albinism, aniridia, because they cannot see anything other than that. Do you think? Aniridia, they'll have severe photophobia. So they'll have vision. They may have almost 6'9" or 6'6" vision, but they'll not be able to open their eyes because of severe photophobia. So what you have to do? Only thing is you give them filters. You give them filters for indoor. You give them filters during evening playtime. You give them filters for night driving. That is the way you manage. Okay, it is not that you have to give optical aids to everybody. No, from patient to patient it differs. Okay, so that's it about low vision rehabilitation. We have a small activity now. Are you ready for the activity? Before that, I had promised you that we'll start the afternoon session by 2 things. One is the difference between eccentric fixation and eccentric viewing. Our boys had gone out to check what is the detailed difference between eccentric viewing and eccentric fixation, and they have come up with the answer. Okay, what was the second activity? To show what is a confrontation. Yes. Come on, boys, who is taking up the volunteering? Yeah. Eccentric fixation, eccentric viewing. മലയാളത്തിൽ പറഞ്ഞു. പഠിച്ചിട്ടുണ്ട്.
ടാർഗറ്റ് ഡയറക്റ്റ്ലി ആക്കി കൊടുക്കുന്നത് എന്തോ ഡയറക്ട്ലി വ്യൂയിങ് വ്യൂയിങ് പറഞ്ഞാൽ ഫിസിയോളജിക്കൽ മൂവ്മെന്റ് അന്ന് ഇവിടെ എത്തിയോ ഇല്ല അങ്ങോട്ട് അറിയില്ല എന്ത് അറിയുള്ളൂ
എക്സെൻട്രിക് ഫിക്സേഷൻ ഫോവിയൽ അല്ലാതെ വേറെ എവിടെയെങ്കിലും പോയി ഫോക്കസ് ആവണ ഒരു ഇതാണ്. അതറിയില്ല.
സെൻട്രൽ സ്കോട്ടമുള്ളവർ ചെരിഞ്ഞിട്ടൊക്കെ നോക്കില്ല.
മനസ്സിലായില്ലേ? You understood what is eccentric fixation and eccentric viewing? After the class, they will tell it in detail. Good thing. Okay. You went and searched for it? No, you knew it. Oh. Okay, anyway. Eccentric fixation means congenitally, if a child has got some macular disorders. See, macula and fovea is a center of fixation. Okay? Fovea is a center of fixation. But congenitally or in the very early childhood, if our central fixation has been hampered because of any condition, for example, corneal opacity, nuclear cataract, or any central opacities, macula is not able to take up the fixation. Fovea is not able to take up the fixation. What will happen? Parafoveal area, any other area will take up the fixation. That means I will be looking like this, but actually I will be seeing her. That is eccentric fixation. Understanding? You have seen people with squint, they will be saying, what is your name? And this way. They'll be looking somewhere else, but they're spotting you. Why? You are falling at a parafoveal area where her central fixation is. So when the main fixation, when the primary fixation is other than fovea, that condition is called as eccentric fixation. When you have a central field defect, when you have a central medial opacity, your fovea, and this should happen in the early stage, then only retina will take up such thing. Okay. Now, you grow older, your foveal fixation was there, you grow older, and you develop a macular degeneration. You develop a macular dystrophy. You develop a condition where your macula is affected. That means when you see, you're not able to see what you're looking at. You're looking at an object, you're not able to see. Then we train them for eccentric viewing. That means if you want to see this girl, if I see like this, she falls on my macula is degenerated, I cannot see. So if I want to see her look like this, she will fall on my parafoveal area or paramacular area, and I will see her. This kind of training, asking the patient to view in a different way and make the image fall. You ask them to read like this. That is called as eccentric viewing. You train them. You train them when the person has got a macular defect, you train them to see through another way. Now, this is not possible now because your macula is healthy enough. Now you cannot do that. But once your macula is blocked, people come and tell, I cannot see what I am looking at, but I can see here. So if I want to see here, look here. If I want to see here, look here. That kind of training is called as eccentric viewing. Understanding? Eccentric fixation and eccentric viewing? Yeah. So, 1, 2, 3, 4, 5, 6. Okay. These two benches, one team. These two benches, one team. These two benches, one team. Two benches, one team. Wait. You three come here. Okay? Those two, one team. You two, one team. You two, one team. Right? Eh? Now that you have, come and sit. Come and sit here. Give the cutaway magnifier. Now that you, say, after the session, how much do you feel you have improved on your knowledge? How much percentage? Genuinely speaking? 10%? 15? 35%? 50%? Good. What we have developed is, we have developed on the knowledge alone. That is not enough. You have to develop on your skill as well. That is very important. Even if you lose something with the knowledge, you gain it up with the skill. Okay? So let's check how well you can manage. I'll give you quick cases, okay? And you have to discuss in groups what and all can be done. What amount of magnification, what kind of magnifier, is a magnifier required, what else will you do, and like that. Ready? Okay. So first case. First case, these are the cases I have dealt with. A 64-year-old male retired teacher, condition was ARMD, independent ADL and mobility, that is the daily living skills, he is able to manage everything, he is able to manage his mobility also. What he needs is his requirement, better distance vision for watching TV and better near vision for reading newspaper, reading and watching television. 64-year-old ARMD patient. Okay? All of you should discuss, okay? A few more information about the case. His distance visual acuity 6/60 both eye and near vision was less than N36. N36, take it for N36, less than N36, but take it as N36. Now what will you do? Now, the patient's visual acuity was tested using a low vision chart, that is, using the Bailey-Lowy chart at 3 meters. The distance visual acuity was 6 by 48, and uniocularly 6 by 48, binocularly it was 6 by 38 minus 1, that is, in that line one letter he could not read. And with the MN chart, you remember the MN chart, the near chart which contains both M notation and N notation I showed you. MN chart, the near vision was N40 parts at 20 centimeters uniocularly and N40 at 20 centimeters binocularly. This is the distance visual acuity with low vision chart. That was with the regular standard charts. Now how do you manage this case? I'll give you 4 minutes time. You will have to tell me what all you did with this patient. How will you manage this case? What all low vision trial will you do with this patient? Ready with the answers? No, ma'am? Yours? Yours? Whose is this? Finished? Ah. This is first case. This is first case. ARMD, retired sir. Ah. Then why 2 visual acuity? Why 2 visual acuity? That is your confusion. This is low vision chart. Bailey-Lovey low vision chart. That was a standard Snellen chart. Finished? One, 2, 3, 4, 5, 6. Yeah. ARMD patient. Very common low vision case. Very common nowadays. Okay? What would be the problems of this ARMD patient?
Central vision.
Very good. First one is, this is a central loss, central field loss. Then,
ഈ സെൻട്രിക് വ്യൂവിങ്ങിനാണ് ചാൻസ്.
okay. അത് പോട്ടെ. അതല്ലാണ്ട് central field loss will be there. Along with that, what all other vision hamperedness will the patient face? What all problems will the patient have? He has a decreased visual acuity.
6.
He has a central scotoma. He will have central scotoma. Then definitely his contrast will be reduced because macular degeneration. His contrast will be reduced. Okay? So 3 things you have to take into consideration. Now what his requirement is? Only 2 requirements. TV viewing and reading newspaper. So how you will manage TV viewing? Watching television.
രണ്ടും കൂടെ കമ്പൈൻ ചെയ്തിട്ടുള്ളത് ഞങ്ങൾ ഉദ്ദേശിച്ചത്.
Okay.
ബയോപ്റ്റിക്.
Oh, you will give a bioptic telescope. That is fine. It's a good thing. They have combined both. But see, bioptic telescope, you will have near vision or intermediate vision with your regular glasses. And this patient has got N40. With that visual acuity, he will not be able to read newspaper. So you will have to give a additional aid for reading. Bioptic telescope, regular viewing for near. And upper portion you will have a telescope attached. Autofocus telescope. Bioptic telescopes are very heavy. So a 75-year-old retired teacher won't be able to use that. That's a good option. She thought of giving a single device instead of giving multiple devices, single device to the patient, but that won't work here. You will have to give separate for distance and for near because his near visual acuity is very less. If his near visual acuity was somewhere near, say N10 or N8, bioptic would be best. But here it is N40, very less. So bioptic won't do. You will have to give a telescope. You will have to give a telescope for distance. But monocular telescope, central field loss, person won't be able to target it. Central field defect, monocular telescope won't do. So you will have to give a binocular telescope. Okay? A binocular telescope. A CTV would be good. CTV would be. CTV നിങ്ങൾ കണ്ടല്ലോ. When I changed the slide, you saw the CTV picture and you might have written that.
അങ്ങനെ ബയോപ്റ്റിക് CTV നോട്ട് ചെയ്ത് വെച്ചിരുന്നു അങ്ങനെ പറയാം.
Bioptic telescopes are good, but they are heavier. Especially bioptic telescopes are used for driving. If driving is a mandatory thing, then you have a bioptic telescope because auto mechanism, automatically focusing. And those are costly, above 35,000 rupees.
എന്നിട്ട് ഞാൻ
So, just for viewing television, he won't spend that much. Okay? CTV would do 12,000, 15,000. CTV may do good. Or binocular telescope will also do good. Did you get the amount of magnification required for telescope?
നമ്മൾ പഠിക്കണല്ലോ.
Magnification? How will you calculate the distance magnification?
ഡിസ്റ്റൻസ് ഡിനോമിനേറ്റർ ഓഫ്
Denominator of best corrected visual acuity divided by denominator of target visual acuity. Here the best corrected visual acuity is 48. Okay, since it is binocular, you can take it as 38. Binocularly you are giving, so it could be 38. Then target visual acuity for television, what amount of target can you give?
ടെലിവിഷൻ അല്ലേ അത്യാവശ്യം ഡിസ്റ്റൻസ് ഉണ്ടാവില്ല. 3 മീറ്ററിന് മേലെ വരില്ലേ ടെലിവിഷൻ.
You can take it as 18 or 12 would be enough for a television because that is at 3 meters distance. So 18 or 12, 12 would be good. So 38 divided by 12, how much will you get? 38 by 12, almost 3x. 3x? Almost 3 point something. 3x magnification of a telescope would do good. Binocular, not monocular. Binocularly, he has got visual acuity 6 by 38. You see why binocular? One more point. The binocular visual acuity is better than monocular visual acuity. So, binocular telescope would do good. Somewhere around 2x to 3x. If 3x is not working, you can shift to 2x and check, or you can shift to 4x and check. Okay? For near, what you will do? Huh? You have train. Okay. You can say Ashwati ma'am and you can go.
നിയറിന്റെ കേസിൽ നമുക്ക് ന്യൂസ് പേപ്പർ അല്ലേ
Newspaper.
EVP വെച്ചിട്ട്
Okay, EVP. You calculated with EVP. What is the magnification now? Everybody, you calculated EVP for this patient? How much you will get?
ബെസ്റ്റ് ഓയുവിന്റെ എടുത്തിട്ട് ചെയ്തപ്പോൾ
Okay.
N40
40. 40 divided by
ഫ്ലുവന്റ് ആയിട്ട്
fluent reading.
Appo
Reading.
N4.
He wants it reading. Yes.
4
4. N8. 8, 6, 5. 5 or 4 is enough. 5 or 4. 2 to 3 lines. N8 is the newspaper print size. So you have to reserve 2 or 3 lines. N8, N6, N5. Okay, so you can take either 5 or 4. So they have taken it as 4, no issues. 40 by 4 into 100 divided by 20 centimeters. Very good.
ആൻസർ 50 50 അല്ലേ ആൻസർ
50.
10 into 5 വരില്ലേ 14 by 4 വരുമ്പോൾ 10
40 by 4 is 10. 100 by
By
20 is
5.
5. 50 diopters.
Diopters.
It is EVP, equivalent viewing power. 50 diopters. What is the magnification? (11x).
EVP
50 divided by 4.
EVP
If it is 44, 11. 11 point something. 12, it won't come 12 because 60 diopters will be 12. This is 50 diopters, no? 11 point something. 11.25 or 11.5x will do. So 11x magnification is required. 11x magnification is required. What you will give? 12 into?
ഫോൺ നോക്ക്
What 12? Okay. 48. So 12x magnification. Okay. 12x magnification, what you will give? 12x magnification, what you will give? 74-year-old
സ്ലൈഡിങ് വെച്ചിട്ടുണ്ട്
handheld magnifier. How long will he hold that? Prolonged reading is not possible. Stand magnifier. Why not spectacle?
ആ ക്ലോസർ
50 diopters means, where is the working distance? Very close, very close. Quite difficult to use a spectacle magnifier. So stand magnifier will do. Understanding? Everything else he is able to manage. Mobility, his normal daily living skills. So only requirement is television with binocular telescopes and reading with a stand magnifier. Very good. You see how we managed this case was, we gave a CTV, binocular telescope, okay, CTV, somewhere around 2x to 3x magnification, and we gave a illuminated stand magnifier. The calculation was, though it was 10x magnification, but with even 7x magnification, he was able to manage reading. So, illuminated. Why illuminated? Lower contrast. Lower contrast, you have to definitely think of illumination. Understanding how you manage a case? So, we'll move on to the second one. I had to get a lot of shout because of this patient from my ophthalmologist. Why? Because this patient had a Stargardt's disease. I don't know, does this happen regularly with Stargardt's? What is Stargardt's? It's a kind of inherent macular dystrophies, okay, congenital disorder, macular disorder. First, visual acuity was taken by my colleague. That was somewhere around 6/12. Then the vision was repeated. It was 6/24. Then the vision was repeated. It was 6/12, 6/18, 6/24. So it kept on changing. So I won't forget this man. A 39-year-old male, a clerical staff. His mobility was okay. He had independent daily living skills and things. Only thing was, since he was a clerk, he wanted good near vision and good computer vision. That's all. So his requirement was prioritized. He will have a number of requirements. But we prioritized his requirements. So now his requirement, in order to continue his job, he wanted to have good computer vision and good near vision. We'll check into the assessments. His distance visual acuity with Bailey-Lowy was 6/36 partial, and binocularly it was 6/36. His near vision with MN reading chart was N16 uniocularly and N12 parts binocularly at 15 centimeters. How do you manage this case? Fast. Yes. Okay. Yeah. This group is ready to present the case. You have done? You have calculated the magnification? Then do it fast. Don't think that your chance is over, so I'll not ask again. I'll come back to you. Okay? How will you manage this case? You ready? Okay. Yes, come on. Patient's requirement is near vision and office work. So how will you do that?
ബൈനോക്കുലർ ടെലസ്കോപ്പ് കൊടുത്താൽ
You can give a binocular telescope, but the patient has got not a distance vision problem, right? A near vision problem and a computer vision problem. So do you really have to give a telescope then?
കമ്പ്യൂട്ടർ യൂസ്
Computer vision. So what?
we will use this
You can think of any
I don't know. എന്തെങ്കിലും അറിയോ
headband frontal magnifiers. Okay, good. You can think of some electronic assistive devices, computer related. So some jaw software or something where his screen could be magnified, his materials could be magnified and seen. Electronic magnifiers could be used. Okay, computer vision. And you see his vision is not that less, N16. It's less, okay, but not that less. So he could manage with electronic devices, assistive devices would help him out. Then anything else? For his near work, what would you suggest for his near work? His requirement, anything specific? No, better near vision and better computer use. Better near vision, that means he is able to manage, but he wants something good, better. Anything else you can think of? You can think of CCTVs. CCTV, again electronic magnifiers, closed circuit television. Okay, computer vision job, so near vision and his computer vision would be enhanced. Then anything else? Star guards, proper lighting, proper office environment, on environmental modification at his office would also do good him. Yes, then to enhance contrast, you can give additional lighting. Okay, see how we manage this case. For distance, a normal refraction was enough. Normal refraction was enough. You remember the visual acuity? It is 6/36. Okay, not that much less. So a normal refraction would have helped him to improve 1 or 2 lines. That would be enough for his distance vision. And then we gave him spectacle magnifiers, because again his near vision was not that less, N16. So his near vision is, if he has to have so much of prolonged reading and writing, a spectacle magnifier would help him. Because you cannot give a stand magnifier for a clerical job. You can, but why you cannot? Because he will have to read and write both. So that time stand magnifiers won't do. And then see, spectacle magnifiers would do good. N16. What was this vision? N16. Binocularly it was N12. Where do you want to improve it to? You have to improve it to N6 or N4. Very easy. 2x or 3x magnification would do, 2x spectacle magnifier would do good for us Near vision. And for computer, you can give him some assistance, software assistance or some electronic devices. And we also gave some inbuilt modification. His office was modified in order to enhance contrast. He was sitting opposite to windows. So we made him to sit away from the window. Contrast was enhanced. Additional lighting was put on to his desk so that he could read and write better in the illumination. So illumination was modified and electronic magnifiers were set into his computers. That was a simple thing that we did. Easy? Is that good? Next case. 13-year-old male child, 6th standard student studying in a regular school. He had undergone a surgery for RD. Okay, he had undergone a surgery for RD, and he had normal IQ, normal milestones and development. His development was normal. That means he was a near normal child. What he wanted is, he wanted to view the blackboard. He was a student, and then he wanted to have good near vision to read textbooks and write his exams. He wanted to write his exams, he wanted to read his textbooks, and he wanted to see the blackboard. Now, before coming into the case, you have started discussion now. Okay? The assessment, the distance vision, RD, case of RD, very, very less vision. 2/38, 1/30 with Bailey-Lowy, and uniocularly it was 2/38. Near vision with MN chart, it was N50 and N64 at right eye. Left eye had undergone the RD surgery. And uniocularly he had N50. Field of vision was as less as 10 degree. So you should think of everything. You can do anything, you can give anything. You want time, or you are directly going into discussion? Directly going into discussion. Okay. So this team will help. What you have done, if this was your case of RD, vision is very, very less, not like the previous two cases we have dealt with. The vision is very less, visual field is very less, child wants to view, distance vision. Binocular, the child has got 2/38 visual acuity.
ഡിസ്റ്റൻറ്റിൽ ടെലിസ്കോപ്പ് മറ്റേ നിയർക്കാവുമ്പോൾ എന്താ പറയുക സ്പെക്ടക്കിൾസ്
Spectacle magnifier.
കട്ടവേ
See, for near we have spectacle magnifier. For near we have cutaway magnifiers. We have stand magnifiers. We have illuminated and non-illuminated handheld magnifiers. Everything can be given to the child. But what will work? What will work? Will spectacle magnifier work for this child? See, that much less of near vision. Where will the child has to hold the near vision object? Very closer to face. So I don't think spectacle magnifier would work for this child. Then what? In order to enhance contrast, you can give non-optical devices like typoscope or something. Okay. But to see, what will you give? The child is having N50 vision. Now the child wants to read his textbook. What is the magnification required? Calculate that first. Calculate the magnification for near first. How much it will be? Calculate the magnification for near. For near. EVP. What is the EVP? Tell me the EVP. It will be 50 divided by?
15 divided by
It will be 50 divided by?
12.
What is the target visual acuity? Come on. He wants to read textbook. He wants to read textbook. The print size is say N14 or N12. He's a child. So it would be N14 or N12. Is a target visual acuity N12? No. Target visual acuity should be N6. N6, N12, N10, N8. At least N8 or N6. At least N8 or N6. You calculate it with N6 probably. How much magnification? I don't think you will get. 50 divided by 6 into 100 divided by 10. So that will be 10. 50 divided by 6 will be somewhere around 9, 8 or something. 80 diopters. 80 diopters, spectacle magnifier. What you will give? Headband magnifiers, they are low magnifiers basically. Only thing is you can go for a prolonged reading. CTV, yes. Bioptic telescope, okay. That will also do good for distance. For near, what will you do? With 40 diopters and 50 diopters of requirement.
Stand magnifier.
We'll have to go for stand magnifiers. Okay? You see how we manage this case? This was, see again, it does not stop here. The patient has got 10-degree visual field. You will have to counsel for the mobility training also. Mobility training also. Child is going for a regular schooling. Writing the exam is difficult. Difficult. What you will do? Arrange a script for writing exam. Okay, you ask a person to write the exam for this child. Okay, see, this is how we manage the case. For distance, approach magnification for viewing blackboard was given. The child was made to sit nearer the blackboard to see the blackboard. That was the classroom modification done. Okay, and then because the child was not able to locate with telescope, that much less visual acuity, he will not be able to see the distance blackboard. So approach magnification was made for the child. Then for near, for reading purpose, child was given a CCTV because prolonged reading and writing, he is a child, he is a student, electronic device, though costly, he has to have a longer period of learning now. He is just 12 years old, no? So he has to learn, he has to complete his 10th plus 2 degree. So CCTV will be very useful for this child. Very expensive, but it will be useful. So we suggested an electronic device, CCTV, they were ready for it. And for writing examination with that less vision, stand magnifier is the only thing that can magnify, but you cannot write your exam with a stand magnifier, so you have to keep a script for writing the examination. Understanding?
Yes.
Other than that, you give a mobility training for the child and you enhance the the child's social activity also. Okay, some extracurricular activities using radios, music, as a child to be happy, and that's it. Okay, good. Last case. Boring? Yes. Yeah. Fourth case, a 25-year-old male. He is an unwaged person. That is, he discontinued his studies at 10th standard, so he is not employed. He has RP. and he has difficulty in mobility, definitely RP tubular vision. He has mobility problem at unfamiliar places. And then what he requires is he requires a better distance vision for getting job. He is not having a job, so he wants good vision for a good job and his mobility task. A 25-year-old man, he does not want to read, he does not want to write. So, the requirement is different for person to person. Okay? So here his requirement, his prioritized requirement are these two. How will you manage this case? Think about it. Assessment, distance visual acuity was 6 by 24. OS by 6 by 19. Uniocularly it was 6 by 19. Near vision was N10 and N8. N8 binocularly at 15 centimeters. But the visual field was as less as 5 degrees. Vision was good. Visual field is less. What will you do with this patient? You will give mobility training? Okay. Then for near, what you will do? Why you need a spectacle magnifier? The patient does not want a near requirement. Did the patient ask for a near requirement? He will not ask, no, he is having N8 partial, he is able to read newspaper, he is able to see his mobile. He will never ask you to enhance his near vision. He is asking you to enhance his distance vision. Not simply distance vision for job. 5-degree visual field, 5-degree visual field, what you will do with this person? It will be very less, no? It will be like you're viewing through a coin. You're viewing through a coin, that much amount he is able to see. He is able to see 612 or 619, whatever, 624, whatever. But only one spot he is able to, the next spot he has to scan his head. What you will do? What vocational training can you give to this person? Anybody? Mobility training, okay. He has got mobility restriction, you can give mobility training. What kind of mobility training? He is an unwaged person. He is not having any job. Will you ask him to buy a dog guide? Will you ask him to buy a guide dog? No. He cannot buy. What you will do? He wants job. What you will do? See, when you rehabilitate a person, think of the person's economic status also. Ma'am, you can give him a CCTV, no? Ma'am, ask him to buy a bioptic telescope. He's not having. Use VZoom. That is one thing. He can use VZoom, that is one thing. Okay, good, far better. But again, field is restricted. He'll have to use VZoom like this. Like a robot. 5-degree visual field is not a small thing. Anybody? What you will do? See, there are so many things, but we cannot manage. I'm sorry. We are helpless. You can go back. See, Low Vision Rehabilitation Center is the last word, is the last helping point for a person. And if anything could be done for that patient, anything, any one small thing could be done for this patient, please do it. Okay? You should not say a no to anybody in your low vision rehabilitation center. See how we manage this case. We gave him vocational training. We didn't give him any vocational training. We asked him to undergo vocational training. Small industrial works where he can sit and do his job. Candle making, sweater sewing, such like of things. Small, what do you say? Small scale industries, Kudil Vyavasayam. Such kind of things you can ask him. With that small vision, less vision, he can do. At least he can go to pack things. Okay, packing of things. One person is required for that. You can send him. He is having near vision. He can pack things. He can pack bakery items. Okay, you can help him out. You can take him, the person, to that place. See, this person has got very less vision. He cannot do normal job. Kindly help him. So that is a kind of social commitment you do towards your fraternity, towards this field and thing. Okay. So it's not like, oh, with this vision, what job he will get? What this man is telling? You cannot say that way. Okay. So such kind of vocational trainings can be done. Then 5-degree visual field, the patient has to undergo a mobility training. Definitely a mobility training. So that's it, we are winding up. So low vision management does not simply mean prescribing. It is beyond that. Okay? Just calculating magnification, giving spectacle magnifier, this does not work. Give a handstand magnifier, this does not work. Give a hand magnifier, this does not work. You should buy a CCTV, that will only work. That is not the point. Okay? You have to go beyond orientation and mobility training. So, something has come like this. You know about this? That cane is okay. You know this? Shoe with GPS. Shoe with GPS. What happens? See, I am walking. My shoe will give me a hint that there is a obstacle. So, there will be a trigger in my feet that I should not take the other step. I am going to hit an obstacle. So I don't need a dog guide, I don't need a person along with me, I know that. Okay? There are GPS systems attached to your spectacle that gives you a hint that yes, there is a camera in front, just one meter away from you, you have to turn to the left, that will be giving you instructions. Okay? GPS systems. So these are the kind of assistive technologies that have come nowadays. Contrast enhancement, like I was telling you, steps more visible with borders, doors and windows more visible with borders, classroom modification, bedroom modification, kitchen modification for mothers and who do cooking. How do you differentiate salt and sugar? Different colors. You give them different colors of dabbas. Okay? Then you can give something like you can feel it. Okay? Some bottles can have a rough surface, some bottles can have a plain surface. You know that this is coconut oil, this is sunflower oil. It is difficult. Okay? For us, you see, and this is coconut oil, this is sunflower oil. But for a patient who has got a lower contrast, for him everything will be same. So it is not easy for everything. Every time he tastes that is quite difficult. So some differentiation you keep on the bottles, you keep some differentiation on the color, you place it on two different shelves. So such kind of kitchen modification is made. How do you identify food from the plate? You give high contrast plates like white rice on black plate. So you identify the amount of rice you are putting, because you will be putting, you don't know how much amount of rice you are taking, because white plate, white rice, you are not knowing that plate is being filled up. So that is called as environmental modification. So it is not simply giving away magnifiers, calculating magnification. Yes, magnification is the key role, but beyond magnification, there are so many other things you can do. Okay, guidance and support, like we were talking about the job assistance, what and all concessions you can, grants you can allow this patient to have. Okay, regarding disability certificates. Okay. So, effective evaluation is the main thing. You properly evaluate the visual acuity, you properly evaluate how much the patient can read. Each and every single word, every single letter is important for a low vision patient. Okay? So, finally, you see yourself to be a best practitioner. All the best that you move forward with your optometry and try to be the good optometrist with passion and knowledge. Thank you so much.
Irshad.
Good evening, all. So, ma'am, thank you so much for being here and taking this beautiful session for our students. And I hope to see you in the future also. And thank you, all of you, for listening and for taking your one Sunday, more informative. And I request Prabhashni ma'am, who's a coordinator of Indian Academy of Optometry, to hand over a token of love to Juberia ma'am. Please come. Thank you, ma'am. നിങ്ങൾക്ക് പറഞ്ഞു പോവാം. നിങ്ങൾ സർട്ടിഫിക്കറ്റ്സ് നിങ്ങൾക്ക് കളക്ട് ചെയ്തിട്ട് അവിടെ ടീ അറേഞ്ച് ചെയ്തിട്ടുണ്ട്, കഴിച്ചു പോകാം. താങ്ക് യു. Ajmal K. Ajmal K. Musin PV. Musin. Falilu. Muhammad Faiz NP. Sia Mary P. Rocky. Hafida TH. Abirami CA. Jomol K. Paul. Sakia Nasrin O. Ansila K. Adila M. Jodiga K. Anshida Hanan. Asna Fatahuddin. Akila K. Najia T. Thank you so much.